Welcome back to Interim Health Committee. We are on agenda item 9, which is the overview of children's crisis services in Nevada. Today we have 3 presenters, Dr. Megan Freeman, Dr. Andrew Freeman, and Samantha Cohen, who will present on this particular topic. I will go ahead and ask them to present when they are ready.
This is Dr. Freeman, Dr. Megan Freeman, for the record. Thank you, Chair Peters. Just waiting for those slides. Okay, the slides are up. I apologize, I can't see them on mine.
They're not on our main screen either.
Okay, sorry, I thought I saw them.
This is Dr. Andrew Freeman. The slides are, I've got them up in Las Vegas.
Well, we were having problems with that down here as well. So BPS, is there a way to get those up and running for us? Okay, we can see them now.
Okay, great. Thank you.
Can't see him online.
Can you not see them online?
No. But Dr. Freeman looks good.
Can't see on Zoom. Okay. Do we have technical services down in Grant Sawyer who could help us out here?
Chair, please stand by, and we are working on that in 1 second.
Thank you so much.
Chair, we just got word that folks online should be able to see the presentation now.
All right. I'm still getting a no.
I think it popped up for a minute. I did see it. This is Dr. Freeman. I did see it for a moment. We also could share the slides from our technical assistants, Dr. Freeman and Dr. Pitluck. I'm not sure what you prefer.
I do see the folks in the building, and I see the slides in little teeny form with them, but not on the screen here. I see a picture of people in there. Now I don't see the slides at all. They disappeared from the people. There it is.
Great, we see it as well.
It's, and now it isn't. But go ahead.
A committee, we have access to this on the legislative website on today's meeting page. So if you would like to follow along there while we are figuring out how to get this up and running, that would be great. And I'm going to just ask that we go ahead and proceed since we still have a little bit of an agenda ahead of us.
Sure thing. This is Dr. Freeman. I'm going to actually ask Samantha to share her screen, and I'll just go ahead and get started while she's doing that. Thank you, Samantha. So this is Dr. Freeman, Dr. Megan Freeman, again, for the record, and thank you for having us to discuss the crisis system for children in Nevada. You can go to that agenda slide, please, Samantha. So I just briefly wanted to talk a little bit about 988 to just do a quick refresher, and then we will, I'll turn it over to Dr. Andrew Freeman. He'll talk a little bit more in detail about our programming here in Nevada. Next slide. So 988 was discussed at the February meeting, but we will definitely want to do a quick refresher because it can be a little bit confusing and overwhelming. It is a big change. So I will do a very quick refresher, and then if there are questions at the end, or if we can send in any information after the meeting, please let us know. Next slide. So as you might recall from the February meeting, 988 will be a single number to call in a mental health crisis, which we hope will become as widespread and stigma-free as 911. Implementation of 988 is mandated by federal legislation, and it will go live nationwide on July 16th of this year. This is a major system shift, and most of us have never seen mental health reform like this in our lifetimes. If you've ever taken Psychology 101, then you probably have learned about the Deinstitutionalization Movement of the 1960s. This occurred in the context of the Civil Rights Movement. There were several contributing factors, including the introduction of the first generation antipsychotic medications as a treatment option for adults, and a belief that mental institutions were inhumane. So over the next 50 years, there was a push to discharge folks from institutions and transfer them to community-based care. And there was approximately a 92% decrease in the number of individuals with mental illnesses living in institutions over that time period. At the time of deinstitutionalization, the plan or the vision was to substantially build out the community mental health system so that individuals with mental illnesses could receive treatment in the least restrictive setting possible. But from the time of deinstitutionalization through today, insufficient investments have been made in community-based mental health, resulting in large numbers of individuals with serious mental illness and severe emotional disturbance unable to get the care that they need. Some people have called this trans-institutionalization because due to mental illness, many individuals receiving care end up receiving care in other systems, such as jails, prisons, or the juvenile justice system. They may also become homeless. The hope is that 988, which is of course backed by a federal mandate, will help all states move towards greater investment in mental and behavioral health care. The goal of every contact with the 988 system will be to find the right level of care for the individual or family in distress, whether that be support through a hotline call or a warm handoff to psychiatric care and all of the different options in between. Next slide. When we look to the children's crisis system, we see that we are missing some important components of a comprehensive crisis response system. Best practices as defined by the National Association of State Mental Health Program Directors outline several touch points, including a crisis call center, crisis mobile response, and crisis receiving and stabilization centers. Underlying each intervention point are the essential principles and practices that have been developed through research and expert consensus. You'll hear more in a bit about our Children's Mobile Response and Stabilization Program, which we call MCRT, which is considered a national gold standard program. MCRT does operate a 24/7 hotline, but because its purpose is to access services, it does not quite fit the definition of a crisis call center. There aren't staff dedicated to simply resolving concerns over the phone, which is what's required at a crisis call center. So with the integration with the 988 system, the children's system will better achieve this touch point. What we're currently lacking but building are crisis receiving and stabilization centers. So Dr. Andrew Freeman will provide some more detail on those, but we want these centers to serve the function that the emergency departments are currently serving. So the crisis receiving and stabilization centers would provide a crisis assessment by behavioral health staff, immediate stabilization, and linkage to the next appropriate level of care. We want children, youth, and adults in crisis to be able to walk into a receiving center and receive care quickly from specially trained professionals instead of waiting for hours or days, or in some instances longer, in the emergency department, which was never designed to provide behavioral health care. So we do have some proposals and ideas in the pipeline for how to stand these up here, and we have a couple of pilot programs or community partners who are providing this service, and we hope to be able to implement it more widely as part of our children's crisis system model soon. Next slide. During the 2021 legislative session, substantial progress was made in laying the groundwork for a best practice crisis system in Nevada for both children and adults. Thanks to the hard work of many partners, some of whom are on this committee and here today, Nevada was one of the first states to pass legislation creating infrastructure for 988 and other elements of the crisis system of care. Nevada additionally recently received several grants and awards for national technical assistance to support us in building out our crisis system as we continue to demonstrate that we are at the forefront of crisis work. I'll turn it over now to Dr. Andrew Freeman to talk in more detail on what our children's crisis services look like in Nevada.
Hello, my name is, for the record, my name is Dr. Andrew Freeman, also known as Mr. Dr. Freeman. And I am currently the temporary manager of our child adolescent mobile crisis response team in Las Vegas and Reno. And I support the rural and frontier mobile crisis teams offered through the Division of Public and Behavioral Health as well. Our goal is to interrupt care pathways. Our goal is to meet youth and families when they are having urgent mental or behavioral health problems, meeting them where they are in the community, not making them come to us, but we go to them, and then to try to interrupt the escalation of care pathways and expense that comes with that. So we are trying to provide family-driven, culturally sensitive care to the families in their homes as much as possible. Our origination historically came out of the emergency room boarding crisis that Nevada experienced in the 2000s through early 2010s. And mobile crisis started in Las Vegas in about 2014, 2015, expanded to Reno in 2016 in Washoe County. And then in 2017, we expanded to cover the rural and frontier counties as well. But the goal was to take youth out of higher levels of care and keep them safe in their homes, and to divert expenses in the system as a big picture cost savings mechanism. When we think about where mobile crisis is now currently and where we need to go to integrate into the 988 system, one of the key messages that we send on a regular basis is that children and adolescents are not simply adults in small bodies. We have developmental trajectories that are different. We have environmental trajectories that are different, and we need to manage those specifically for children. And we can't simply take them and plug them into an adult system and hope everything works just fine. What we're seeing in the national 988 conversation is the model is coming out of an adult-based model that is running effectively in other jurisdictions like Maricopa County in Arizona, the state of Georgia, among other places where they have a very effective crisis now implementation that diverts adults from higher levels of care. In Nevada, we're in the opposite situation. We have very little to no adult mobile crisis services, and we have a established child and adolescent mobile crisis system. And so we were working very diligently to make sure that when 988 goes active in July and over the next couple of years, that the child and adolescent system integrates into the larger 988 system. So again, through the Division of Child and Family Services, we provide mobile crisis response teams in person in Las Vegas and the Reno metropolitan areas. And the Division of Public and Behavioral Health, through their rural and frontier clinics, provides telehealth-based crisis services for the remainder of the state. We are a busy service. We tend to operate at or above capacity. In the last 12 months, we saw about 2,400 youth for initial responses statewide, with about 1,800 of those happening in Clark County in the Las Vegas metropolitan area. To give an idea of what this system will look like and probably grow in over the next 5 years is that external consultants estimate that in Clark County alone, we should be doing between 3,800 and 4,000 responses a year for children and adolescents. And so we have to take our entire system and double it just to meet the needs within Clark County. And so there's a lot of growth and potential for this to really change how children and adolescents access services. Our backbone of this service is a hotline. If a family wants, if a youth needs services, they call the hotline, and our hotline, we operate 24/7. We share it throughout the state. And we've gotten substantially busier over the course of the pandemic. Our hotline has increased 20 to 40%. Our number of responses have increased about 40% over the last fiscal year. But the simple question is, when we talk about mobile crisis, we need to ask who can get this service. We operate on a fire department model and not on a doctor's office model. So if your house catches fire, you pick up the phone, you call 911, and the fire department comes and they put out the fire in your house, and then they leave. They don't pull up to your house, call your homeowner's insurance policy, and ask if prior authorization is necessary and what paperwork do they need to send. They don't wait to say, oh, your insurance doesn't cover us, you need to call this other fire service, and they will come and help you when they have time. We serve any child or adolescent under the age of 18 in the state of Nevada, regardless of ability to pay. And for crisis services to work, we need a robust system that allows for all payers to contribute to the system. That way, we can serve every single child or adolescent in the state, regardless of their personal family's ability to pay for that service or not. And to access us, like I said, all you have to do is call our hotline. For historical reasons, we have a Las Vegas number and a Reno number. The reality is it brings into the same place, the same people answer the phone, and we centrally dispatch. Once we dispatch, what we are trying to do is create the safest environment possible in the family for the youth that is in crisis. Kind of one of our fundamental beliefs is that when a child is in crisis, their parent is in crisis. As a parent of a 4 and an 8-year-old, when my children are struggling, I'm struggling. And so what we're trying to do in that initial crisis response is a period of de-escalation and then a crisis assessment to do an appropriate determination of level of care that's necessary. Along with that, and that's driven by safety. Do we think we can comfortably, reasonably keep this child safe at home with their parents? And the answer is about almost 9 out of 10 times, 87% of the time, the answer to that question is yes. Through intensive safety planning and follow-up services, we can keep a youth safe at home and divert from having to go spend time in an emergency department or go to a psychiatric hospital. When we do that, we then provide intensive in-home services to help maintain a period of stability as we link and do care coordination. Our referral patterns vary depending on where you are in the state. In Las Vegas, we were instituted primarily to help with emergency departments, help our emergency department partners with the psychiatric boarding crisis they're experiencing. And so we continue to serve emergency departments as a large proportion of our visits. We also serve Clark County School District and help with our charter schools, our private schools as well. In Reno, we tend to do a little bit more of a split between emergency departments, parents, and schools in a way that we don't quite have that same mix in Las Vegas. In the rural frontier region, their Distribution looks almost identical, except for they serve emergency departments substantially less and more self-referrals. But when we think about the 988 system, the 988 system is predicated on this kind of triage level of care. So if we call the hotline will handle 80% of calls without doing anything else. They'll simply talk to the person on the phone. And so they'll take 20% of those calls and dispatch mobile crisis teams. When we talk about children's mobile crisis and the emerging national standards and the model that we work under, is the goal is to get the child with a clinician and the family with a caseworker as quickly as possible. So we tend to deploy 80+% of the time. We do a lot less of this idea of care traffic control or care coordination over our hotline. We've started to do it a little bit more to keep up with the demand that we're experiencing. But we really want to get professionals to the family to support the family as quickly as possible, so that way we can make sure that we can ensure appropriate levels of care are being provided. Over the next couple of years, we're going to see kind of a bridge from what we're currently doing to what we will need to be doing to function within the 988 system. In July, there'll be 4 numbers that a person could call if their child is in crisis. There's always 911, which we discourage as much as we can, because a law enforcement officer is not who we want responding to a child in crisis. Their 988 will be active, and then our 2 mobile crisis numbers. The goal over the next 5 years is to kind of have a very rapid 911-like implementation. So I grew up in rural Ohio in the 1980s and moved to Nevada about 7 years ago as a professional. When I still remember as a child, when I would go to friends' houses or go to a cousin's house, there was a magnet on the fridge with the local police and the local fire number, because 911 didn't exist. So our goal is to do that exact same thing. Is over the next 5 years, the local numbers fade and 988 becomes the primary entry into the system for children and families in crisis, the same as it is for adults. We have work to do to get there. We have to invest in our technology within our team so that we can interoperate with the 988 Care Traffic Control Center appropriately, feasibly, and well. Part of this is also creating a safer environment for our mobile teams. So when our teams go out into the field, we are working on investing in mobile technology that allows us to geolocate them at all times. It allows the teams to check in and out and have safety checks online via their phones. This is one of the joys of modern technology, is that we're allowed to keep our folks safer in the field with time. Mobile crisis, in the 988 model, they talk about 3 critical elements: someone to call, someone to go, and somewhere to go. The Children and Adolescent Mobile Crisis Team is fundamentally someone to go. And during that crisis response, our goal is to be there in under an hour. And in some parts of Nevada, that is very feasible and easy to do. In Las Vegas, we can, from our kind of central location, we can get to most of Las Vegas within 30 minutes. In Reno metropolitan area, we can be most places within 30 minutes. Our rural frontier teams respond by telehealth, are usually connected with a family in under 15 minutes. If we wanted to have people in person, though, that becomes substantially more difficult, because now we're talking about very large geographic stretches that we'd have to travel. That is on the plate. We are working on solutions to that, including through community-based partnerships with our CCBHCs, as well as proposed multi-county, in the rural frontier regions, there's a proposed multi-county mobile crisis response team, county supported. But we send a master's level clinician and a psychiatric caseworker who's a bachelor's level paraprofessional. And the idea here is we can wrap you in services from day one. So we have our licensed master's level clinician taking care of the mental health, behavioral health, medically related needs, while our caseworker is taking care of all of those other supports that a family in crisis needs help with. They are the caseworkers, the person that is doing a lot of lifting and linking and referring families to outpatient care, both therapy and medication management, but also building informal supports, activating family and friends and other supports in the community to help keep a youth safe at home as much as possible. When we think about what do we do with youth after, what do we recommend? 6 out of 10 youth, we're going to keep internally for a period of crisis stabilization, internal to our team, where we see them about twice a week for 45 days. In the last year, during the pandemic, our diversion rate has decreased some due to the lack of access to community-based services that moved online into telehealth. And those are starting to turn back on, so our diversion rate is moving back to our historical number of about 87%. But we will refer about 15% to 18% of youth to psychiatric hospitals. When we do this, we facilitate that care. We seek out, we contact the hospitals, we find the youth a bed, and we facilitate getting the youth to that hospital. For about 1 in 5 youth, we refer back to an existing community provider, and if we work with the family to get them back to that community provider faster when possible. When that's not possible, we will continue to provide check-ins to make sure everything is okay, even if it is 2 weeks from now when they see their psychiatrist or their nurse practitioner or their therapist. And occasionally families will say no thank you, and very rarely we will have instances where nobody in the response thinks additional services are necessary. When we look at this compared to the adult model that is driving 988, the kind of fundamental thing here again is that children are not tiny adults. They're just not a grown-up in a small body. They've got a lot of development left ahead of them. They've got education. They've got a lot of growth to do. When we talk about children's mobile crisis, we're talking about a period of de-escalation, a time-intensive de-escalation, where we perform a comprehensive crisis assessment, and we try to do this without law enforcement present. And it's not because we dislike law enforcement, it's because we think that law enforcement are better served keeping the community safe and allowing mental health to be handled by mental health professionals. In the adult model, it's a very rapid, fast crisis triage, and a large chunk of it will be handled with law enforcement co-response through most teams or CIT, crisis intervention trained officers. And so we're trying to shift who is going where to provide appropriate care. In the adult model, we would move an adult to services very, very rapidly and let that next service pick up care as rapidly as possible. In the child adolescent model, we tend to stay with the families a little bit longer. And when I say when I say a little bit longer, we typically will stay with the family up to 45 days. In the adult model, it's usually a 72-hour intervention. The biggest challenge that we face is getting to adequate staffing. I said earlier that we do about 1,800 responses per year in Las Vegas, and we predict that we need to be able to do about 3,800 to 4,000 responses per year in the next 5 years. That requires a substantial expansion in staffing that, as a state-provided direct service, we probably will not be able to meet that need. So we are partnering with our CCBHCs, our Certified Community Behavioral Health Centers, to train their staff how to respond and how to provide a gold standard response to children and adolescents as well as adults. And then we have those kind of big picture safety concerns. When our implementation teams in the 988 system talk with our law enforcement partners, their number one concern is it safe to send a clinician and a caseworker knocking on somebody's door? What I can say from our mobile crisis service and our 7 years of experience is the answer is yes, it is safe. We have had violence. I've had glass thrown at me. I've had one of my clinicians 6 months ago had a brick thrown at them, but we also have not been injured. We are able to keep ourselves safe. We have not had any critical incidences in terms of safety. So the answer to our law enforcement partners is when we triage the system and we appropriately deploy law enforcement-based teams, we can keep everyone safe. In thinking about this someone to go model, we are very fortunate that our existing child and adolescent mobile crisis team is one of 3 national gold standard models identified by SHMSA and other partners in nationwide. So we're starting in a really, really good place. What we have left to do in the big picture is we probably need to do some expansion of our state-based services, but we also need to encourage and develop partnerships with private entities to start providing these services as well. We also need to expand our hours of availability because that is entirely dependent on staffing. So our hotline operates 24/7, 365. In Las Vegas, I can have a team to you in person 24/7, 365. In Reno, we have teams from 9 a.m. to 8 p.m., 7 days a week. And in our rural and frontier counties, we are 9 a.m. to 8 p.m. Monday through Friday. And so getting to 24/7 availability requires increases in staffing. And then we also need to upgrade our technology. The mobile crisis response teams we're a very resilient group of people. When people ask me what my job is, I describe it as organizing chaos. We respond when somebody calls us, not when we have it available in our schedule. And so what we've done over the years is we have bootstrapped our system and we have made do. What we need is a fairly substantial investment in upgrading our technology to keep our team safe, to increase efficiency, and to get people to where they need to be faster. Another big piece of this is our partnership with Nevada PEP, our family peer support specialists and partner in the children's crisis system. They were one of the driving forces to get children's mobile crisis up and running. One of the things that we're actively working on is increasing the use of our family peer supports. We are starting to lay the groundwork to start exploring co-response models so that we can have a true paraprofessional with the clinician instead of a fully trained and paid caseworker. And then we also need to kind of increase the robustness of our casework training. One of the things that we've been working on is figuring out what exactly are the limits of a paraprofessional within the current Nevada Medicaid policies and procedures, as well as licensing laws and rules, so that we can maximize our use of lower level providers. At the end of the day, one of the critical pieces is that the 30 to 60 days after a child goes through crisis is the critical period where recurrence is most likely. And so that is where kind of we start thinking about our crisis stabilization. When we talk about the 988 system, we're talking about kind of 2 different places of crisis stabilization. One is the mobile crisis team responds, keeps the youth internally, and provides crisis stabilization. The second is through this kind of new entity called a crisis stabilization unit. The simplest way to think about a crisis stabilization unit is a CSU, a crisis stabilization unit. It's like urgent care. When you are sick, when your ear hurts, you don't need the full power of an emergency department, but you may need to go see a physician or a physician-like practitioner, like a physician's assistant or nurse practitioner, to get ear drops or a prescription, and they may diagnose you and see you and say, no, you actually do need to go to an emergency department, and because you're having a heart attack, not an earache. Hopefully that doesn't happen, but they do have that capability. A crisis stabilization unit for children and adolescents has to kind of follow the same basic mobile crisis principles. They need to accept everybody regardless of ability to pay. They need to be able to accept everybody and not require medical clearance first. So we don't want a situation in which we send you to the emergency department for an emergency department to say you are medically stable and then send you to the CSU. We want them to have the ability to address mental health and substance use needs. And we want our first responders. We want our law enforcement, when they get called out and they determine that a youth is in crisis, they committed a crime potentially, or a community member was concerned for them and called 911 because they didn't know who else to call, to be able to rapidly drop a youth off. And the goal is that the law enforcement could drop the youth off in 5 minutes or less. When we get this fully up and running, that is the hope. Versus law enforcement can regularly spend hours dropping a youth off in an emergency department. And so this is a way of kind of diverting and changing the flow through the system. These crisis stabilization units are then responsible for coordinating care transitions through inpatient, outpatient, and connecting youth to appropriate services rapidly. There is a version of this model that we are exploring where the mobile crisis teams may then also support those CSUs and provide more crisis stabilization, that intensive in-home 45-day period, where we see those youth for 2 to 3 times per week. And this is, we earlier presenters talked about when a youth is struggling and having difficulties, it's not just one-on-one therapy with the youth. It's therapy, it's working with the entire family system and to get to a homeostasis or an even-keeled place where everyone is managing and everyone is doing okay, and then slowly build towards thriving. So again, our crisis stabilization units, the goal here is to have extremely short-term care that's less than 24 hours, that coordinates ongoing care, and gets youth to the appropriate level of care without burdening our emergency departments. So the whole idea here is diverting away from expensive care to less expensive care in the system. For this to be successful requires coordination and partnership throughout the system. And the reason why this is so important is that when we look at discharge rates from psychiatric hospitals, the recidivism rate, for lack of better terms, the rate at which youth return to care with just kind of typical discharge plans is somewhere between around 25% that youth will be back in an emergency room within the next 2 months, the next 60 days. What our mobile crisis team has been able to show over the years is that roughly 9 out of 10 youth do not return in the next 4 months to an emergency department for mental or behavioral health care, and they do not access psychiatric hospitals in the next 4 months. So we are doing even better than kind of our traditional inpatient unit with diverting from higher level of cares. In the policy implications of standing up 988, when we talk about billing and getting all payers on board, one of the best things that y'all could do for us is consider ways to get all payers in the system to reimburse for crisis services. Very recently, the Medicaid managed care organization contract was rebid and reinstituted, and one of our small victories there is that our Medicaid HMOs now are required to pay for our service. So we now cover about 50% of the youth that we see in Las Vegas are paid for through Medicaid as a mechanism. But this still leaves about a third of our youth who have private, typically employer-based or healthcare exchange-based insurances that do not support the mobile crisis system, even though they access it. The second big policy area is workforce development. We've seen over and over from Dr. Megan Freeman's slides to start us off and through the school slides that we're short mental health providers. There's no way to say that besides we need more mental health providers. That is we are missing people from the system. Policy level consideration on how do we expand our base of mental health providers is critical, whether it's through thinking through can our higher education partners do 3+2 models of clinical education that were pioneered in states around medical education where they have 3+4 for physician degrees. Can we do something similar for mental health professionals? Can we invest in and expand our university partners' master's level clinician programs? These are programs that tend to produce less research dollars, but they provide a critical element of our provider base in the state. And then the last big policy picture is that for this system to function as a system, we need metrics to be reported. We need to know how each piece of the system is functioning, and that way when we start to identify something's not working, we can rapidly respond to it versus waiting for it to completely fall apart. And then kind of the very last thing is when we start talking about the system of care that children and adolescents need, we are simply missing parts of the system. We don't have intensive in-home services. We don't really have we have a very small sliver of peer-operated respite care. But functionally, it does not exist for most of the youth in the state of Nevada. And we don't have enough short-term residential facilities that are varying levels of care. So as of right now, there is no crisis stabilization unit for children and adolescents in the state of Nevada. We have identified a partner and we're working on helping them get set up so that we'll at least have one to get us going in the very near future. But we also are short just acute psychiatric beds, particularly for northern and rural Nevada. And then kind of thinking through that crisis level of care, most kids, like I said, 9 out of 10 kids just about mobile crisis, we can get them safe, we can help them stay safely and thrive in their home environments. For 1 out of 10 kids, they go to an acute psychiatric hospital. For a subset of those youth, they then need follow-up care. We're short those beds within the state. We don't have robust intermediate care facilities or psychiatric residential treatment facilities. These are facilities that for youth who are not so acute as needing 24/7 high-level care in an acute psychiatric hospital, but they're not quite to a place where they're ready to go back home. They still need a structured environment with ongoing support for 3 to 6 months. And so increasing that access through is critical to building a robust crisis system. Thank you, and I'm happy to take any questions.
Thank you so much. I especially appreciate your last slide there showing kind of our gaps and places where we can work. I made quite a number of notes about why these are not places that we've effectively been able to encourage our private industry sector to move into. I have a couple of questions, but before I go ahead with mine, I guess I should ask first and foremost, are your presentations over, or do you have another section of presentation at this moment?
Our presentation is over on the Children's Crisis System.
All right.
We are open for questions.
We will go into questions. Committee, are there any questions in Las Vegas or on the Zoom?
I have a question, Madam Chair, and I believe Assemblywoman Titus also has one as well.
Yes, please go ahead.
Thank you so much. Thank you for that presentation. It was very informative. I guess I'm going to start with the easy question. How do we get this going 24/7 all across the state? And I say that joking. I know that's the very hard question. But in earnest, I do want to, if we have an opportunity, sit down and come up with a roadmap to get this done for both children and adults all across the state 24/7 within the next whatever's feasible, right? 5 years. I mean, it'd be great if we could do it tomorrow. Could you just, and I know you spoke to it a little bit, but could you just highlight, some of the obstacles? Is it money? Is the biggest obstacle staffing? Are those two and are those, the same thing? How do we really get jump started on expanding this so that it's as effective as it can be?
Hi, thank you for the question. For the record, Cindy Pitlock, Dr. Cindy Pitlock. I serve as the administrator for the Nevada Division of Child and Family Services. That is an excellent question. We are working directly with the governor's office and the governor's finance office, and of course through Director Richard Whitley to pursue these opportunities to secure ARPA funding to solidify and expand our mobile crisis unit. We are working hard together as a collaborative team in order to not only increase our services, but also to hopefully be able to increase our presence within the school districts as well as a complementary service to them. And I'm sure that Dr. Freeman has, of course, other comments, but I did want to jump in and introduce myself and let you know that I am sitting here to answer questions as well. But I brought you the A team today, and I know that you recognize that, and I'll let my subject matter experts also pipe in. So thank you for the question.
So this is Dr. Andrew Freeman for the record. To rapidly expand, we need to expand our provider base. And then we also have never tried, to be very honest, we set out, when we set up our Rural Frontier Mobile Crisis Team, the goal was to provide telehealth to the Rural Frontier region because we didn't think we would be able to get in person because it's a very, very large area. With the transition to the 988 system, one of the key partners that is coming online are the CCBHCs, the Certified Community Behavioral Health Centers. They are required to stand up mobile crisis teams. They have a much greater reach throughout the state than we do. As those teams turn on, as they stand up, as we teach them how to do mobile crisis really well, how we kind of help them and partner with them, we will get to more and more in-person responses throughout the states. There will still be pockets of the state that we may not be able to get in person to. I'd like to go camping. Baker, Nevada hosts Great Basin National Park. It's a population of a couple hundred people hours from the next population center. And so we may always be in a situation where for some parts of our very frontier region, parts of the state, we may be telehealth based. For a place like Elko, that's still considered rural, they have a CCBHC that CCBHC is actually one of farther along in standing up their mobile crisis teams than many of our other CCBHCs. So we need to continue to kind of partner with those groups and stand those up. The other piece of this is exploring kind of alternate models. So kind of the gold standard model is the clinician and the caseworker, or the clinician and a family peer support specialist show up in person. What other states have done, particularly in their rural regions, Oklahoma is a really good example of this, is that they deploy a caseworker and a family peer support specialist in person, and they telehealth the clinician in. So that way, in a region like Las Vegas, where we have more clinicians than, say, Elko or Pahrump, that we can still be in person and providing the service. So I think what's left on the plate is expanding the services. A critical element of that, though, is getting reimbursement rates to cover the cost of the service. So quite frankly, Medicaid accounts for about half of the youth that we see and for about 30% of our budget.
Thank you for that. And Madam Chair, if I may just have an additional question. Thank you. I know we're focused on children in this particular meeting today, but I've been working on corrections issues, and a lot of what I hear is we've got people who are just having mental health issues, staying in jail for 90 days, just waiting to get a competency hearing. And could you talk a little bit about how this model might be used once we stand 988 up to possibly divert some of those folks from going into the system once they've kind of had an interaction with police officers. I mean, is there that ability there? Do you think we need a whole new model? Or do you deal with that when you have juveniles who may have committed a crime in the course of having some mental health crisis?
So this is Dr. Andrew Freeman for the record. So the national data looking at the 988 system believes that somewhere between 10 and 15% of 911 calls are mental health related and not criminal matters. Yet we still, in Nevada and pretty much everywhere in the United States, still deploy law enforcement. And so things that could be handled in a mental health care setting now become a law enforcement setting. They now, in most places, the county jail is the single largest provider of mental health services in that county. And so the idea here is instead of calling 911, we call 988. Instead of a law enforcement officer with handcuffs, a gun, a taser, a badge showing up and doing what they know how to do, a crisis response team shows up and engages and provides appropriate service. And so if we can, and the goal is to divert. For adults particularly, it's diversion away from criminal resources, kind of our criminal system, our legal system. For children, it's both diverting away from the legal system, but also keeping children at home in their families as much as possible.
All right, thank you.
Thank you, Senator. Did Dr. Titus also have a question?
Yes, thank you, Madam Chair.
Please go ahead.
Thank you for your presentation. Thank you for your presentation and what you're doing, both Dr. Freeman's. I just, a couple comments and an observation. First, question on, you testified or presented that the crisis hotline was open from 9 to 8 in the north. Is that correct?
This is Dr. Andrew Freeman. The crisis hotline is open 24/7, 365. We answer it primarily out of Las Vegas. So it is always open. You can call that number and you should be able to get a hold of us unless we're having technical difficulties.
Okay, because I heard it was, maybe the response team would be available 9 to 8?
Yes, so our response teams are in-person responses. In Las Vegas, I have teams on 24/7, 365. In the Reno metro area, for most of Washoe County, we have teams on 7 days a week from 9 a.m. to 8 p.m. In our rural and frontier region, we have rural frontier-based teams Monday through Friday, 9 to 8.
So just to be clear, though, when I have this issue, and I brought this up at one of our IFC meetings regarding the crisis hotline for COVID, when it was identified in my Quad County. I'm the county health officer in my rural county, and they had this, and it was listed as a crisis hotline for COVID-19. And I called it one day just to see what the response was going to be, and it said, "Well, we're sorry, you're called after hours. You can't get us, and call back on Monday." And I was like, whoa, if you're going to be identified as a crisis hotline, I want to make sure that there's somebody that answers that. And I was just listening to the 9 to 8, you get a response, but there will always be a voice answering that phone, not a recording, when somebody dials that mental health hotline, correct?
Yes, ma'am. And this is Dr. Andrew Freeman. Yes, we answer the phone 24/7, 365. Our technology is, like I said earlier, is bootstrapped, and it is up 98% of the time. But when you're talking 24/7, 365, 98% is not quite good enough.
Right.
So we are actively investing in upgrading our phone service so that we can be up like Gmail or Outlook is, and we're up 99.9% of the time or something.
So, Okay, so just, I'm an old doc, and I've also been in this legislative process now and on this particular committee for 4 terms, and we hear about the term no wrong door, and we've been talking about 211 for a long time. And will the 988 replace 211 or just augment 211? Because one of the goals of the 211 service is to be able to get people to the right spot. And again, I worry that we're throwing around a whole bunch of numbers. And how do you educate a community not to dial 911? We still have a 211 number out there for other services. And now we're going to have a 988 number. And I'm just curious as to, will they all be able to feed off of each other when ultimately this gets done?
This is Dr. Andrew Freeman for the record. So Dr. Stephanie Woodard through DPBH is leading the 988 implementation initiative for the state, for the Division of Public and Behavioral Health. I am involved in many of those 988 meetings. One of the goals is to get the phone numbers to work together. So that way, if you call 911 and it's a behavioral health or mental health crisis, that they connect you to 988. There are multiple models being explored. I don't know that we've, as a state, have chosen a specific one. But the goal is to get to interoperability through our 988 call centers with our 911 call centers specifically.
Great, thank you. And so I sit I'm the legislative representative on our Northern Nevada Behavioral Health Care Board, and have been since its inception. And we continue to talk about the legal holds on not only adults but on youth also. And you mentioned when you have your mobile crisis about when you respond in person and diverting. As a doc, I've literally thousands of hours in emergency rooms where I have filled out those forms and trying to find a place for these folks to go. Ideally, it's nice to divert them from emergency rooms where you can get them to either the care or you can diffuse a situation. And one of the concerns during these legal processes is that medical clearance, as you mentioned, I believe in your presentation, about not needing that medical clearance. And so I haven't really seen actually that legislation has happened, although we were working on our policy board to probably clarify that the mobile crisis team could perhaps do the basic medical clearance if you're going to then, hey, this person really does need to be taken to a location. Are you addressing that at all in the youth side of this?
So Dr. Andrew Freeman for the record. Through the standards for the Crisis Stabilization Unit, I believe are being set through Medicaid policy. So Medicaid is setting the standards of care for expectations of what will be provided as a billable service, and that is the way that we're implementing the no medical clearance. And again, the goal of a crisis stabilization unit is to function like an urgent care, so that I, as a mobile crisis team, could bring a youth there if necessary, or a youth could walk through the doors and receive care without having to call me first or call 988 first.
Thank you for that. However, one of my concerns is that without some medical provider or some ability to, perhaps this youth has low blood sugar, so they're acting out because they've overdosed, perhaps the mental health crisis is related to a medical problem. If you don't have a medical person there, are you going to be clearing these folks?
Dr. Andrew Freeman for the record.
Dr. Megan. Can I jump in?
It is all yours.
Yes, please
Sorry.
go ahead, Dr. Freeman.
Titus, thank you. This is Dr. Megan Freeman. Dr. Titus, we can get you the requirements for crisis stabilization centers, but there is requirement for nursing on site, and I believe there needs to be a medical director. I don't want to tell you the wrong thing, but there are, I hear your concerns, and there are certain elements of the staffing built in to ensure that although medical clearance isn't needed or necessary or required, there's still that oversight occurring.
Great, thank you. I know these are hard questions, and I know that not everybody at the table has all the answers, nor certainly wouldn't pretend that I do up here, but these are concerns that we have as we address this moving forward. I'm highly supportive of the mobile crisis, going to the scene, diverting these folks, young or old, where they need to go, not just the youth, but across the spectrum on who they are, and married to a retired sheriff. We certainly don't want them going to our jails. And if we can divert all of that, I think it's a great ideas, and coming to the scene is good, but there's lots of questions also. So thank you, Madam Chair, for the questions.
Thank you, Doctor. I kind of want to ask a question along the same lines related to general access to some of these additional resources that you outlined in your presentation. So, and Dr. Pitlock, I'm grateful that you're here and for your statement about the joint efforts that are ongoing to address some of these dynamic issues. But I'm particularly interested in how we can help ensure that and my computer just froze on me, so I can't get to the slide. But how we can help get private industry or other entities involved in some of these services that we really need available to our youth. These include our peer support in service housing stuff. I'm sorry, I don't have them in front of me now because internet. But you had a whole list of things that we don't have enough of, right? Services we don't have enough of. Who are our partners? Who do we need to be reaching out to? And what can we be doing to pull them in and make sure that we are encouraging those industries to place themselves in Nevada?
Thank you, Chair Peters. This is Cindy Pitlock for the record, Administrator of Division of Child and Family Services. Excuse me. So that's a great opportunity for me to give a pitch to our provider summit that we're going to be having in April. And I'm sorry that the exact date escapes me, but we'll make sure that we push that date out. The purpose of that provider summit that we're coordinating with and through the governor's office is to really bring a huge array of partners to the table to talk about our service array, where the gaps are in that service array, and hopefully partner with those businesses and entities and stakeholders that may be able to help us fill those gaps. Of course, the conversations that we've been having all day today tie into the sustainability piece, right? We want to make Nevada a great place to live and work. We want to have Medicaid rates that are sustainable as an ongoing concern for these businesses that need to keep their doors open. We need to have a robust workforce in order to be able to fill the needs as we bring these businesses in with these various specialty areas that we're talking about. So you can see it really ties all into one big package. And I thank you for that question. But we are definitely looking at the whole system of care, finding out where those gaps are, and inviting players to the table to help us fill those gaps. And I know that was a very general answer, but I hope that I steered it somewhat for you. We're also, again, looking at the opportunities for ARPA funding to get these things up and running and seed these opportunities, and then we need to together work on the sustainability piece. So now is our opportunity for standing up and seeding these ideas, and then we need to take that next step in the sustainability piece.
Thank you for that response. And absolutely, I found the slide. It is slide 35 for the record and for our notes. That would be our intensive in-home services, peer-operated respite care, short-term residential facilities with varying levels of care. And I think that those go beyond our need for with children's behavioral health. I could see these expanding into women's behavioral health and being a model for other behavioral health demographics, and hope that we get to see some great models come out of your efforts. But whatever we can do to help, please keep us posted. And if you could get us the date of that that event, I think some of us would love to be able to come and listen to hear how stakeholders are feeling about your proposals.
Chair Peters, Cindy Pitlock for the record. Yes, absolutely. And while we're having a provider summit that is highlighting youth and families, we're also looking at filling the service array gaps throughout our populations of health. So, excuse me, our summit will not be focusing solely on children and families, but throughout the lifespan as well. So I really see this as a great opportunity to bring all of us together for this very important day, and we'll make sure that we get that information out to you.
Wonderful. Thank you so much. Are there any other questions from the committee? I don't see you, so if you have a question, please speak up. Okay. No further questions on this particular item. Thank you so much for presenting on this. We appreciate your time and effort today. We will go ahead and move on to agenda item 10. This is an overview of specialty services for youth with disabilities and behavioral health needs with a focus on gaps and challenges. We have a couple of folks in the room up here in Carson City today to present on this issue. Do you guys have folks on the Zoom or down in Las Vegas as well? On Zoom, great. We have a couple of folks on Zoom as well. We'll go ahead and let you introduce yourselves, and please proceed when you're ready.
Thank you. I'm Dr. Elaine Brown, and I serve as the Chief Psychologist for Aging and Disability Services Division, Developmental Services. I have with me Deputy Administrator Jessica Adams, along with Deputy Administrator Ricky Robb, and Health Program Manager Samantha Jaime. Do we have our slides up here?
That is a really great question. I think we have some staff in the room who can help pull that up.
Do we have it?
Right along the top, and they're named for agenda items. You guys are 10, right?
There we are. Thank you.
You're welcome.
All right, there we go. So I'll be talking just for a few minutes about youth with disabilities and behavioral health needs. Specifically, I'll start with definitions and descriptions. We'll talk about some special considerations and then go into more specifically what is our current system for youth and for children with disabilities. And then, as was mentioned, the services gaps and challenges. I'll start by what is meant by youth with disabilities. And one of the things I'll emphasize is we're talking about youth first. So if we're talking about all children, all youth, it will include youth with disabilities. And this is important for informing policy and public health in determining sort of the scope of need as we build our children's services. Overall, the very broad term that's used from a public health perspective globally is disability. Any impairment that makes it more difficult for a person to do activities or participate in their community life. For developmental disabilities, the CDC collects information and has a very broad term that's used of developmental disabilities occurring in a developmental period, typically that's under age 22, and that it results in impairments in physical, learning, language, or behavior areas. These are the conditions that can exist throughout one's lifetime, and about 1 in 6 children have a developmental disability. So for example, a physical disability can result from scoliosis. A child can have a learning disability, a speech and language disorder, or a behavioral concern like ADHD. All of these can be considered disabilities under this definition. There's also a term developmental disability that has a specific definition arising from the Developmental Disabilities Assistance and Bill and Rights Act of 2000. It's more specific to identifying disability as a severe and chronic and attributed to mental or physical impairments, likely to continue indefinitely, and results in substantial limitations in 3 or more major life areas. Intellectual disability, this is a condition where a child or adult evidences substantial limitations in intellectual functioning and adaptive behavior. And we often use the term intellectual and developmental disabilities as a broad term that combines the field. And we use the acronym IDD. We have in NRS 435 definitions that are related to our long-term services and support system that is lifespan for children and adults with intellectual and developmental disabilities. The main difference in NRS definition of developmental disabilities from that of the DD Act is it more closely matches a federal definition of a related condition. In other words, these conditions that may result in lifespan support needs for children and adults. So for the purposes of planning, it can be helpful to consider the prevalence based on these definitions. So if I take a very broad definition of disability and youth with disabilities, we're looking at about 1 in 6 children, so 18%. If I'm talking about intellectual disability, that's about 1 to 3% of our population. Autism, which is considered a developmental disability, is 1 in 44 children. And then there are many other conditions that we can identify where children may need more or less supports, either early in their life or throughout their lifespan. For example, cerebral palsy is a type of developmental disability, 1 in 323 babies. And then there's all kinds of other types of conditions that can result in disabilities and support needs for individuals and for children. So when we're talking about youth with disabilities and behavioral health needs, we're really talking about youth. And what I will talk a little bit about is broadly intellectual and developmental disabilities and some of what we see in terms of the behavioral health needs that are there for these youth and children. The majority of children with developmental disabilities can benefit from the same behavioral health services, the same crisis intervention services that are provided to youth without any identified disability. And these can be provided with little, if any, modifications to the treatment and interventions. This is also true for many youth with autism, with intellectual disability, with cerebral palsy. All of these youth can benefit from the same behavioral health and health care in general that we provide in our communities. Youth with intellectual and developmental disabilities have a higher rate of behavioral health disorders compared to youth not identified with disabilities. These estimates can range from 30 to 50% of youth. That's a huge variability, and it often depends on how you're defining disabilities, how you're defining the behavioral health disorders, but there is definitely a need there for these youth and for their families. Those estimates are in comparison that if you take some estimates for youth in general, the general population, you're looking more along the lines of 15 to 20% have a behavioral health condition that's identified. An important consideration is that there's evidence that the behavioral health disorders of youth with intellectual and developmental disabilities are more predictive of barriers to community life and to quality of life than the severity of the child's intellectual or developmental disabilities. It is the largest barrier that they may experience. Additionally, the well-being of parents and families appears to be more strongly influenced by the severity of the co-occurring behavioral health disorder than by the severity of the child's disability. So within this special population, this is a very significant public health issue for our communities. Children with intellectual and developmental disabilities are more likely to experience adverse childhood, or more likely to have adverse childhood experiences, parental separation, death, sexual abuse. The research also supports that adolescents with intellectual disabilities will experience the same precipitating factors that are known to negatively impact the behavioral health for youth, but they experience more of them. They experience more of the bullying, more of the trauma, more of the isolation, and more of the stressors in general. For youth with disabilities, it can be somewhat helpful to know about the increased risk. So there are some types of disabilities that are associated with increased risks for behavioral health conditions. And I'll just briefly give some examples. For youth who have Down syndrome, around 30% of young children have some type of behavioral difference. In other words, some barriers to participating in their family and social life and community life. Youth with Down syndrome, about 15% experience depression. And they have other types of behavioral health and behavioral challenges relative to their peers. Fragile X is the leading inherited cause of intellectual disability and has a very high association with multiple behavioral health disorders. This includes ADHD, very high association with anxiety, and a very high risk for aggression and self-injury. It is also well established that autism spectrum disorders are associated with significant increased risk for many behavioral health conditions. These range as high as 75% in some studies, that there are comorbid behavioral health conditions for youth and adults with autism spectrum disorders. There are times when specialized consultation or clinical services are needed when there's a greater degree of disability, but often it depends about the contributing factors. Is there a contributing health factor? Is there a severe behavior disorder that results in severe aggression or severe self-injury? Then we need to have more specialized services. There's considerations that need to be given to establishing that our services and service delivery systems across all aspects for families and child support for behavioral health are aimed specifically with intention to include all youth and youth with disabilities. And now I'll have Jessica talk about our ADSD service delivery system. Thank you.
Good afternoon. I'm Jessica Adams, the Deputy Administrator for ADSD over Developmental Services. On Zoom, we also have with us Ricky Robb, who is the Deputy over both Nevada Early Intervention and the Autism Treatment Program, as well as Samantha Jaime, who's the manager for the ATAP program. So currently within ADSD, there are 3 different programs that can touch and serve youth. Going on to the next slide, we have the Nevada Early Intervention Services. This serves very young kids from birth to 3 that have a diagnosed disability or developmental delay. It's no cost to the family. It's all in their natural setting, and they really do provide several different types of services, from service coordination to occupational therapy, speech therapy, basically anything that youth may need to hopefully overcome any developmental delay that they have, so that they can graduate at 3 and no longer need services from us. The Autism Treatment Assistance Program, or ATAP, focuses on individuals who have been diagnosed with autism spectrum disorder up to the age of 20. Their main service is applied behavioral analysis, or ABA. Anyone in that program is also assigned a service coordinator that can help them with other sorts of services like parent training, getting them connected with speech therapy, things along those lines. And then developmental services, we are the group that serves people with intellectual or developmental disabilities per that NRS 435 definition that was earlier in the presentation. We have 3 regional centers across the state that does this. Sierra Regional Center, which is Washoe County, Desert Regional Center, which is Urban Clark, and then Rural Regional Center, which has 8 offices across the rest of the state, based here in Carson City. As Elaine said, these services are lifespan services, but we will bring kids in as young as we can. We serve currently about 7,500 people. 23% of that group are youth under the age of 18. Listed here, I've given some services that we currently give to children. Service coordination is one of the big ones, so that they can get connected with other services that child may need. We have in-house psychological services, just like Dr. Brown, that can give different levels of assessment and assistance. We have nurses that can help when we get some of those kids that might be medically fragile. And then we do have some levels of services that are given by contracted provider agencies that are really meant to try to keep that child in the family home, and get them services that are really needed for their IDD. So service gaps and challenges, you're going to hear several of the same things that you just heard in the last crisis training. So first off, we have an inadequate provider network here in the state. In the developmental specialist, or the developmental services realm, we really do lack providers that have the needed skill and training to work with some of these kids that have some of these very high-level needs. We have tried very hard to get some national agencies to come into the state to work with us, and we've heard two reasons. I know you were asking last time why we can't get agencies. The 2 reasons that we have personally heard is our rates. So within developmental services, our rate currently is $24 an hour. That's not very much money when you're talking about what somebody needs to be doing in these family homes. A rate study was completed not long after the last legislative session ended. It was mostly based on data from 2019, since 2020 COVID data got skewed everything. And it did found an overall rate increase of 26.9% was needed across all of our services. However, those rates were based on an average staff wage of $13.90 an hour, which at the time might have been okay, but as we all know, with the current economic wage environment, is not high enough, so even raising rates 26.9% isn't going to really do a whole lot of good. The other reason that we hear that providers are having difficulty coming into our state is they're worried about finding workers. And it's not just those direct staff that go out to the homes, it's trying to find some of the licensed professionals. Several of the out-of-state places are in much bigger areas where they have multiple colleges and universities around them, and so they're able to have multiple internships and other sorts of training programs and all of that kind of stuff to be able to come in and work in their programs. I do have the date for the Provider Summit. It's April 19th down at the Las Vegas Convention Center, but we can certainly get you some more information on that. Along with trying to get new providers, our current providers are experiencing extreme staffing shortages. Every provider that I talk to has at least about a 20-25% vacancy rate for staff. Some are as high as 50%. As I said, we do serve lifespan. About 77% of our population are adults. Many of those adults are living in their own homes. They're living in 24-hour settings. And so essentially, if we don't have staff working with them, it means they're going to be homeless and not have anyone there to help them. So staff does get sent to those settings at this point because the staffing is so bad. We just heard a lot about the mobile crisis teams. We have been doing a lot of work with DCFS and trying to pair with them. I have not had conversations with them about the mobile crisis teams yet, so I think there's a really good opportunity at this point in time for us to pair with them and make sure that we have some specialized training, see if there's a need maybe for somebody who has an IDD background to sit on those teams, so that we make sure that people are getting the right services when one of those teams goes out and say the child has IDD, excuse me. Respite care. All of the respite care in the state right now, for the most part, is a self-directed model, meaning we give money to a family and say, go find your own care. There is no sort of drop-in center. There's very little overnight respite care. Respite is really essential for preventing caregiver burnout. And so we really have to figure out ways in which we can boost up respite and make sure that it is easy for families to access. The daycare and before after-school care, there are very few entities in the state that will accept children with various disabilities, including kids that have all of these complex needs. There are some states that have added a child care supplement to their home and community-based waiver in order to incentivize providers to take kids that have special needs. So that's something that our state could also be looking at. And then the crisis prevention planning. As you heard, all of our services do have service coordination with it, so we try our best to plan for crises, but when we have a lack of services to send people to, it's limiting as to what we are able to do now. And then for the next slide, you're going to hear later about the system of care with DCFS. Our biggest push within the system of care is that kids with IDD are a part of that. We are really lacking. I mean, again, you just heard from DCFS about the lack of beds for residential treatment centers, hospitalization. There are even fewer beds in this state that will take kids with IDD. So we have often kids end up going out of state if they need that level of stabilization. And then once that stabilization happens, we have even fewer settings for them to come back to. So we have been working with DCFS, Washoe County, Clark County, our child welfare agencies, some of the advocates and legal agencies across the state to figure out how do we make appropriate 24-hour placements, whether they are step-down services so that kids can can keep stabilizing prior to them going into the family home, whether they maybe need just some sort of temporary out-of-home services to gain some, skills. And then we also need to figure out for those kids that have IDD, how do we get them into placements that maybe the families aren't ever going to be able to bring them back into their home? How do we get them into services that are going to make sense? Settings that have been tried in the past have been mostly shift staff settings, and I don't believe anyone thinks that a child should be raised with shift staff. So we have a lot more work to do to figure out how to get, foster care settings that are really able to work with this type of youth. And then finally, as you heard last time, more intensive in-home services. So if we can find the providers, we can get the rates. One of the things that goes along with this is the intensive service coordination. Currently, we only have our regional center down in the south. Desert Regional Center has a program called the YIS program, which is the Youth Intensive Support Services program. Those service coordinators carry a lower caseload. There is a full-time licensed psychologist and mental health counselor that works with those families and teams. So they really get a lot more services from us to be able to hopefully learn skills and better keep their child in their own home. So with that, I think, any questions?
Thank you so much for that information. Sounds like there are a couple of things that we can knit together from just these presentations we've had today, which is great and encouraging that we're bringing people into the right space to talk to each other. And I hope that that continues outside of the walls of this room as well. And also want to extend that we're here to help connect you if you need a space to do that. I'm more than happy to do that. Are there any questions from the committee on this presentation? We do have 2 additional agenda items to get to and public comment. So if we can keep these questions brief, please feel free to reach out through either our staff or through these this office in particular for additional questions if you have them. But I will entertain a couple of questions now. I hear someone's mic on in Clark.
Madam Chair?
Yeah, go ahead, Dr.
Madam
Titus.
Chair. Thank you, Madam Chair. I have a question. How many Nevada children are currently housed out of state for mental health issues?
Jessica Adams, for the record. I do not have the number of all mental health youth out of state. I believe within those that are open to the regional centers, we have roughly 9 to 10, but I would have to get you the exact number. But if you ask DCFS or the other counties, they may have some other kids that they know of.
Great, thank you. I mean, perhaps our staff could look at that too, and perhaps DPS. HS could help with that too and get an overall number of what that reality is. Second, how long does it take to train somebody? You hear all the time about we don't have enough staff, we don't have enough staff, we don't have enough professionals. For somebody to actually make a difference, what's the, one of the things I'm looking at is a doc. We're short docs, we're short of nurses. There's a national network right now looking at it's called a National Health Career Network that has access to these professionals throughout our nation. I'm just wondering what solutions are we coming up with? And perhaps in the interest of time, you may follow up with that. Where's the solutions here? We're talking about inspiring more healthcare professionals. We're talking about, again, a national network. We're talking about career development, competency standards for employee, all those things that we list. And I'd like to hear from these different agencies, perhaps that presented today, where are the solutions? And we can complain all day long, but it would be nice to know how long it takes to train somebody and how we're solving this problem, because I keep hearing that it's just always a lack of personnel. So you don't have to answer that right now unless you have a quick answer, but otherwise I'd love to have some follow-up on that. Thank you, Madam Chair.
Jessica Adams, for the record. So I do believe that if we can move forward with our rate study, that would help quite a lot. The way that those rates were developed, it was to make it into an actual ongoing job, including health benefits and PTO and like all of those sorts of things that many of these people don't currently get. As far as training goes, we are looking at multiple different ways to try to increase training. There are some national programs for that. We don't have an answer yet, but we are looking into that.
Thank you. I appreciate that response as well. It was one of the questions that I had, which is a follow-up item, if you don't mind. And if you already have this in the works, that's also fine. But you said that the 26% increase from the 2019 rate study is not sufficient. Can you send us a memo stating some rationale about what you expect that to be? It doesn't have to be definitive, but just what you expect it to be so we can start talking about it and thinking about it. And I also serve on the IFC, and also I think most of the committee does. So if you send it to all of us, then you get a double down on that particular information. So I had 2 follow-up items, if you would. Thank you. Are there any other questions for these presenters today? Seeing none, thank you so much for being here. Really appreciate your presentation and hope we can continue working together to further these. I'm going to go ahead and move us on to agenda item 11. Which is our presentation on Nevada's Children's Mental Health Consortia, structure, role, priorities, and policy considerations. We have allocated 20 minutes to this presentation. Because of the time this afternoon, I'm going to make a hard stop on that. I apologize, but I hope we can get in the information that we need during that period of time. I have Ellen Richardson Adams, she's the chair of the statewide Children's Mental Health Consortia, and Dan Musgrove, who is the chair of the Clark County Children's Mental Health Consortium. He's available to answer questions as we have them. So Ms. Richardson Adams, are you available to present? Hello, thank you.
Hi, good afternoon. Good afternoon, Chairwoman Peters and members of the committee. For the record, my name is Ellen Richardson Adams, and I'm representing today as the chairperson for the statewide Children's Behavioral Health Consortium. With me today via video is Dan Musgrove, chair of the Clark County Children's Behavioral Health Consortia. As you have heard today, children's behavioral health is a top priority within Nevada. Thank you for this opportunity to speak on behalf of the consortias who have dedicated many years to strengthening systems of care, family-focused supports, and respectful and individualized services for our children and adolescents within Nevada. NRS 433B.33 and 335 establishes the mental health consortia based on county or regional populations and outlines the memberships and its missions. Currently, Nevada has 3 regional consortias, Clark County, Washoe County, and 1 representing the rural communities. By statute, each region submits their 10-year strategic plan and annual status reports and budget requests to DHHS. The statewide Children's Behavioral Health Consortium provides statewide governance and guidance related to children's services. It is constructed of regional members and stakeholders to provide a voice for families and children for an array of timely services in the least restrictive environments. Systems of care and financing of services for quality care are also reviewed. In addition, the group provides cooperation and consultation with the regional behavioral health boards and the Commission on Behavioral Health with DPBH and DCFS. The statewide role is to be the voice of the regional consortias and elevate priorities in unison. While currently only the regions are listed in statute, there was an effort on behalf of the consortium last session to establish the statewide consortium through AB 273, sponsored graciously by Assemblywoman Gorlow. While the bill did not make it through the legislative process, the presenters appreciated the opportunity to attempt to memorialize the statewide consortium. The handout provided today is a summary of the priorities of each of the regional consortias. The strength of each region is the demonstration of each community's needs and goals. Common themes across the three include prevention and early intervention with timely access to services, an array of service options to meet the unique needs of families and children, sustainable funding for existing programs such as mobile crisis response teams, systems of care, and family peer-to-peer services. Support families and children through quality service options in the least restrictive environments, and supportive services and supports for youth transitioning back into their home communities. There are common themes amongst the regions for strengthening services for youth, adolescents, and their families. Each region has identified their unique methods and strategies to meet these needs. Some include policy support, while others identify fiscal sustainability. Thank you for this opportunity to present and welcome any questions at this time.
Thank you so much for that that presentation, as well as this list. If the committee would like to review the handout, it is on our website on today's meeting, and it is it's detailed. I would encourage you to look at that, as I will. Are there any questions from the committee on this particular item? I can't see you, so you're going to have to speak up if you have a question.
I think we're all good down here. Thank you, Chair.
Fantastic. We were looking up the bill number that was referenced and are still in the process of...
Madam Chair, it is Senate Bill 273.
Fantastic. Okay.
Assembly Bill, excuse me. Assembly Bill 273.
Great. And my understanding is that there was a fiscal note on that, which is what caused it to not make it through the process. So that is definitely something that we can continue talking about if it's of interest to folks. I would encourage you to reach out and work with our fiscal staff as well as the funding body. And I would like to thank, I'm sorry, Mr. Musgrove, he had requested that he have an opportunity to respond to, I think, a previous question that was made earlier in the meeting today. So, Mr. Musgrove, if you are available, please go ahead.
Madam Chair, I am here, and thank you so much, Dan Musgrove. I'm the outgoing chair of the Clark County Children's Mental Health Consortium, and as many of you know, I've been working in this area of concern for a very long time. Actually, I've been working in mental health issues since Senator Hardy was in local government. So that's how long. I just felt that it was important, as you can see all of our priorities statewide. I think it's important that we stress that, Clark County especially, but it's happening in Washington, it's happening in the rurals, is in an absolute crisis right now. You've heard all day about lack of adequate funding. You've heard of lack of folks that can help us, staff that is skilled to assume a lot of the positions. We don't have enough private folks in the state. We don't have enough state facilities. But I want to stress that from the governor's office on down, everyone is aware of it and working so very, very hard, whether it's the governor's office, whether it's Director Whitley, whether it's Administrator Pitlock, Doctors Freeman, et al., Clark County, and all of the folks who work in this area. But, state government moves very slowly. And it's concerning to us that a number of these programs still have funding sources that could potentially go away. And like whether it's tobacco funds for mobile crisis, the ARPA dollars that we're using to backfill some of these programs. And we need the help of the legislature to really support the governor and the executive staff, and as they build their budgets right now, to look at augmenting these programs from top to bottom, because there are families that are willingly and unwillingly turning their kids over to child protective services because they have no way of dealing with the issues that their children are going through. It's tragic. I know a number of legislators are joining in the weekly meetings that we have, the monthly meetings that talk about Child Haven and what the employees there are going through. but that's not just in Clark, it's statewide, where we just don't have facilities and places that Dr. Freeman Andrews talked about so eloquently about the continuum of care and how we handle crisis. But more importantly, how do we prevent folks from getting into crisis in the first place, giving parents and families the support they need. And so as someone who's worked in this a long time, I just thank the chair for taking this long day to talk about children's mental health, for sharing her own story, and making this such an integral issue that this interim needs to look at and be prepared to really work on hard during the next regular session. So thank you, Madam Chair. Thank you, legislators who I know are tremendous advocates in this area. And we thank you for your consideration today of all these issues.
Thank you, Mr. Musgrove. Really appreciate you and the work that you've put in on this area, and look forward to continuing to work towards better Nevada for our kiddos. I also want to take a point of personal privilege to just kind of reflect back on my earlier sharing about my own story with mental health, and just express that after sharing that, I received multiple messages from people in and out of different areas of my life who shared that they have also dealt with mental or behavioral health, and that they, I guess I want to share that because you're not alone. None of us are alone. It's hard to talk about the things that we go through, especially when it's vulnerable. But I think it's important that we share with each other to ensure that we create these networks and the conversation that's so necessary to have about ensuring our communities are whole and taken care of, and that the supports are there to make sure everybody gets what they need while we navigate this crazy world called humanity, right? So thank you for all who reached out. I appreciate it, and I hope that you are willing to share your stories with other people as well. I think unless there are other questions from the committee, we can close on this item. And are there other questions? I'm not seeing Clark County or Grant Sawyer, so if you have questions, please speak up. All right. Well, thank you so much again today for presenting on this issue and on the consortiums. Really appreciate your work and look forward to continuing on the conversation. We're going to go ahead and move into agenda item 12 today, and this is a longer one, but I think really necessary for us to talk about right now. Where agenda item 12 is regarding transition to a system of care model in Nevada, community-based services and supports for children and youth to address their mental and behavioral health needs. We have quite a few folks who are presenting, so I will let them introduce themselves as they come on, but please go ahead as you are ready.
So I think that's me. My name is Elizabeth Manley, Liz Manley, and I'm a senior advisor for health and behavioral policy at the Institute for Innovation and Implementation at the University of Maryland School of Social Work. And I provide technical assistance and consultation across the country, specifically around children's behavioral health systems design, how to organize the financial systems, policy, practice, all kinds of things. I've been at this work for about 4.5 years. And prior to that, I was the Assistant Commissioner for New Jersey's Children's System of Care, which is an integrated system of care that allows for services and supports for children with moderate and complex behavioral health needs, intellectual and developmental disabilities, and substance use challenges. New Jersey has full-time 24/7 access to mobile response and stabilization, which you heard from Dr. Freeman. Nevada is working very hard to get there. They also have access to high-fidelity wraparound, which is intensive care coordination and all kinds of other things that we'll talk about here today. I'm happy to take questions at the end after we work through some of these really foundational elements that I think might be helpful. Next, please. The next slide, please. So for me, it's really important just to sort of set the context And the context, it really is that what works best is anything that increases the quality and number of relationships in a child's life. It's the people, not the programs, that change people. But what's really important in this idea is that we need skilled, trained adults to actually be able to help young people with some of the challenges that lie before them, in particular as we move from out of the challenges of COVID and some of the other national conflicts that are happening at this time. Next slide, please. For me, it's about language. I'm just going to move really quickly through this and just let you know that one of the low-hanging fruit in systems transformation really starts in the way that we think about and talk about young people and their families. One of the most powerful tools in our tool belt is the ability to level the table and have parents sit with professionals so they make decisions about what's going to happen for their family as we bring in communities to help solve some of these major challenges. So you'll hear me through the course of today's presentation really talk a lot about the role of home and community-based services and the role of ensuring that adults know what to do and how to do it in order to help their own children and to help their communities to be able to heal. But we want to start by talking about children, youth, and young adults. Really important for us to just understand that that's a level setter for a lot of systems transformation. And I'll just bring your attention to one other word in here, and that is the difference between treatment and treatment interventions and placement. This idea of where a child puts their head on a pillow is incredibly important for states to organize around treatment interventions being effective interventions and not just trying to find a safe place for a young person to sleep at night. Next slide, please. So I want to talk briefly about Olmstead, and I'm certainly happy to take questions later about Olmstead, but what's really important about Olmstead is that it is a Supreme Court decision that basically says that an individual has a right to live in the community and be provided services and supports that are necessary in order to meet their needs. What's also important is that to know is that impacts children as well. The children's rights can be violated if they are not in the right service and the right time for the right duration. And we can meet the needs for many, if not majority of young people in their homes and communities. And we've demonstrated this work certainly not just in New Jersey, but in other states across the country. One other thought about Olmstead, I just wanted to say is that Olmstead, many states have really addressed Olmstead challenges through the framework of systemic care. They use it as an organizing framework, and the core components are the way that they transform and move away from Olmstead as a challenge. And a couple of states, just to bring to your attention, include Illinois, Michigan, Massachusetts, and Washington, who have all really used the framework of systemic care to begin to address their Olmstead challenges. Next slide, please. I wanted to talk a bit about residential interventions and where they fit. One of the challenges that states and communities have around residential interventions is they tend to think that they sit really outside of the idea of the other services and supports in the array. And what's important about residential interventions when they're most effective and impactful, residential best practices, as you will, there's a couple of really core components that are important. One is that there's a ton of oversight, and that oversight is not just about following the rules, it's about moving towards best practices and making sure that we learn the lessons from practice-based evidence as we see young people do well and what interventions have been helpful in them for them to do well. So that's one really important thing. In order to do oversight, you actually have to have a group of people who know and understand what residential best practices are. They have to be trained and skilled and able to coach and teach those residential partners. That's number one. Number two, it's also important to have the connection to home and community-based services. In other words, young people who are in residential intervention really are continually to be connected to their families, they're connected to their communities, and they're connected in the aftercare or the next steps while they're still in a residential intervention. So these important concepts are really, it's necessary to understand how they fit within the system of care framework in order to fix it, in order to make sure that young people get what they need. And I'll give you a couple of examples of what's really important in this conversation. One is that we understand the scope and breadth of the number of young people who are in residential. Two, that we understand how long that they are, whether they're in state or out of state, whether they return home quickly, and what the outcomes look like. The data and the ability to share that data and to share the stories of young people is important. Two, we want to make sure access is available to a whole population of young people. They don't have to touch on a child welfare system. They don't have to touch on a juvenile justice system in order to access care. That the funding is available for a young person who meets the clinical criteria, requires the treatment, and we can demonstrate what the benefit for their residential treatment is. Three, we want to make sure that the length of stay is short, intensive, but not too short, right? And by what that I mean, we want to make sure that the young person gets the right service at the right time for the right duration in order to ensure that they're successful upon transition, and that the transition back into the community includes the services and supports that are necessary for their success. Residential interventions are the most costly part of any service array in any state, is where you put the money. And if we want that money to pay dividends in the long run, we need to make sure that we're really have the right children in those residential interventions, and that those residential interventions are fully supported with the best evidence available in order to provide the best care available. Next slide, please. Systemic care is really about values, and it's how we make decisions about where we're going to put resources, where we're going to support relationships, how we're going to spend time putting things together for young people and their families. But it also says that we value what young people and their families tell us, both from a peer support perspective, from an advocacy perspective, but also at the table in which the decisions are made. That leadership and governance are part of the way in which oversight happens, and that governance happens both at a state level, but it also happens at a local level. And that these two components of governance are incredibly important to ensure appropriate feedback loops are in place, that there's transparency around data, that there's transparency around gaps in services, and how we're going to solve the problem of getting what young people need at the time they need it for the duration that they need it. That we're culturally and linguistic competent, and that there's an equity piece to this that ensures that that any child who needs help is going to get that help at the time they need it. That there's a robust service array that includes intensive in-home services, but also includes informal supports or capacity to get to informal supports for young people. It includes intensive care coordination, mobile response and stabilization. It includes services and supports like an in-home therapist, evidence-based practices like functional family therapy or multi-systemic therapy. There's a whole service array that can be that's important as part of this work. And that we're meeting the sense of urgency with the sense of urgency when families are beginning to experience or watch as their child is experiencing changes in their behavior. What happens is that parent begins to experience some worry and some anxiety around that. We want to meet that parent's sense of urgency with the same sense of urgency that they feel. That it's trauma informed, and that there's intensive care coordination in order to manage and work with young people and their families. And this is a really important concept that that sometimes is misunderstood, how it works and how important it is in systems transformation. And then certainly the data and the outcomes. Next slide, please. Now, this is a definition of systemic care, and I'm just going to say two things about this slide. One is that we really want a comprehensive spectrum of effective services that is well coordinated, and that there's a real important focus on meaningful relationships that, and we're spending time and attention around building those meaningful relationships to help young people and their families. Next slide, please. This is a historic challenges within states. And I see this in many of the states that I work in. This was certainly New Jersey's story before we started the systems reform in 2000. And that is the lack of home and community-based services, this idea that we're going to focus on medical model. The patterns of utilization don't take into account what's happening in and disproportionality, that there are poor outcomes. We spend a lot of money on very poor outcomes in a lot of these states. That there's rigid financing structures. One of the challenges is how do you fix those rigid financing structures? And then how do we actually bring stakeholders aboard, and how do we train all of the adults who are going to touch on the child's life? All of these things are important in consideration. Next slide, please. And this is how we get to transformation. We look at policy, the population of focus, we pay attention to the regulations, we look at management, we want to make sure that management has the tools they need around data collection and CQI systems, but also around training, technical assistance, coaching, all important. In practice, we want a single assessment tool across the full population of young people that we're serving. Most states use a tool called the CANS, the Child and Adolescent Needs and Strengths tool, so that we can begin to see patterns of where resources need to go in order to meet the needs. But more importantly, we're collecting the right information to be able to ensure young people get what they need at the time they need it for the duration that they need it. And that community partners drive a lot of this work. Next slide, please. The frontline practice shifts. I'm not going to spend a lot of time on this, but it's important to know that the frontline has to change, right? We need clinicians to think differently about children, youth, and young adults. We need frontline staff to change, and I'll make some comments about that later, but it's just important to know that there are shifts in all parts of the system. At the end of the day, people begin to think differently about the work and how they provide the work, and that includes how they pay, how they bill, how they talk about it, how young people are diagnosed, how the assessment tools are used. All of those things shift in a true system of care. Next slide. Really, the most important thing on this slide is you want to move from a fragmented service delivery system to a coordinated service delivery that's going to help you anticipate where and when you're going to have challenges and put the resources in those places. One quick example means that when there is a natural disaster, as there was in New Jersey when Superstorm Sandy hit, we knew exactly where to put those resources in order to meet the needs for young people to stave off the behavioral health tsunami that we saw coming after the impact of Superstorm Sandy. What good systems of care do, what good and modern systems do, is they actually not only allow you to deal with the day-to-day, they allow you to get ahead of the curve on what's going to happen later. Next slide, please. The system of care is first and foremost a set of values and principles. It says that we are going to honor our children and families and their voice, and we're going to have those children and families at our table. It also says that we're going to meet their needs with the right services at the right time for the right duration. That includes a comprehensive service array. We do not make children fail up or fail down in services before they get what they need. In other words, when children need a residential intervention, we might get that for them. When they need outpatient, we get that for them. But in order to do that well and to ensure that we're making that it is the right service at the right time, there are many steps in between there that have to happen. That these system of care is trauma informed and understands the impact of trauma, not just on the child, but on the family and on the community, that it pushes for partnerships, that there's good care coordination that happens so that everyone is on the same page and there's a coordinated plan for what's going to happen next. All of these things are incredibly important when we talk about what a system of care is. But the other thing that it does is it allows us all as a workforce to move in the direction together. We have a vision of where we're going to go. We speak the same language. We coordinate across disciplines to ensure young people get what they need without having to move one direction or another to go down the street in order to get those services. Next slide, please. We can go one more slide. Thank you. So one of the things that's really important is that system of care is really about family-driven care. And that means parents play a role in a service like mobile response, as an example. And you'll notice that I don't use the word crisis when I talk about mobile response. And that is because nationally, what we know is that parents think that they have to be in a different point in order to ask for assistance and help. And that professionals believe that young people have to wait longer in order to access services. And so in a family driven care, we're talking about when the parent picks up the phone, asks for help, we're going to send it and provide that care that's necessary for them at the time that they need it in the place that they choose. Next slide, please. So youth guided means that we're going to have young people sitting at our table. That means all young people are going to sit at our table, that they're going to help us make decisions for what is in their best interest, because they're going to guide us to what they're ready for, when they're ready for it, and how they're ready for the interventions that are necessary for them in order to get to the highest level of their own potential. Next slide. We're going to slide through a couple of these real quick, and that is that in the system of care, we talk about cultural and linguistic competence, really important. It's an important concept that we're happy to share later, but we're going to move to the next slide, please. I do want to spend just a minute talking about why it's important to have a customized service array for children, youth, and young adults. And that adults really require different things when it comes to meeting their needs and from a mental health perspective. As an example, in the world of mobile response, we're talking about a place to contact. We want young people not only to call, we want their ability eventually for them to be able to text if that's what's necessary in order for us to be able to assist them. We want somebody to respond, just like in the adult world, but we want those responders to have the ability to do a crisis assessment, and we want to be able to connect the dots for families on what's necessary. But the third part is we want a system to connect to, right? We want young people to stay in their own homes, schools, and community, and we think it's really important for all folks who are working with children, youth, and young adults to understand not only what's going on for that child, but what also is happening for their parent and their caregiver. Next slide, please. And it's really important when you transform your behavioral health system to think about not just one reform or one part. We want to reform all of the parts that feed into, right? So using Medicaid as a vehicle for long-term sustainable change is important because they're the largest provider, the largest health insurer in any particular state. And so we want to use that Medicaid and health reform to be able to make differences for young people and their families. But also the Family First Plan, we want to connect the dots between what's happening for Medicaid and what's going on in the Family First Plan. We want to use things like alternatives to detention and restorative justice practices in the juvenile justice world to connect the dots, and educational reforms as well. So in other words, we really want to create win-win-wins across the system to ensure young people get what they need without having to touch on other systems that they don't. Next slide, please. And so the question becomes, why are outcomes so poor and costs so high? Well, there's a couple of things to know, right? A siloed approach to service delivery is really problematic. It just is, because you're paying cost over here. You don't have good assessment. You don't know if you're providing the right service. There's not good coordination around whether or not it's working for the young person. We don't have good feedback loops, and we don't have the data that tells the story. And that's a very expensive way to provide care, right? It's much more cost effective to provide the right service at the right time, but the right duration, because then we're sure that those interventions are going to help those young people be able to thrive later, which is ultimately the goal. And if we can have young people thrive right now, then it's more likely they're going to complete school, that they're going to use behavioral health system when they need it, for the duration they need it, no more, no less, and that they're going to move to the highest level of their potential. So really important for us not to only recognize how much does it cost us in the day, but how much does it cost us over time if we're young people to be in the wrong intervention, and then what is the impact on that young person over time. Next slide, please. And so there's a growing conclusion, right, by states, by tribes, by local purchasers, that we want to redirect spending from the highest intensities of service of such as residential interventions, inpatient care, emergency departments, to home and community-based services. And that we want those services to be delivered within a system of care framework. Next slide. In 2013, SAMHSA and CMS actually sent a joint bulletin to the children's behavioral health directors across the country. I actually happen to be the children's behavioral health director at the time in New Jersey, and this did land on my desk. And they, in the joint bulletin, they basically said, we think in every Medicaid plan, every child should have, who meets the criteria, who needs these services, if you will, should have access to intensive care coordination using wraparound. They should have access to peer and youth peer support services, intensive in-home services, respite, mobile response and stabilization, flex funds, and trauma-informed systems and evidence-based treatments to address trauma. That was all laid out in that letter. And it's really important to know all of these things can be available through Medicaid, right? Medicaid can support this work moving forward. Next slide, please. And the home and community-based services include, by the way, this slide should say, this is what mobile response and stabilization has, which you already have many of these core components, as we heard from Dr. Freeman today, around home and community-based services, care coordination, on-site face-to-face therapeutic response. And we would argue that we want on-site therapeutic response, and 100% of the time that a parent picks up the phone, asks for help, that we should send it. That the access should be 24/7, because parents, when they learn that the behavioral health system is not responsive, then they don't call back and they wait a long time before they pick up the phone and ask for help. So all of these things become really important in terms not just in what you're trying to provide in the moment, but the message you're trying to deliver to the parents and the caregivers who you're trying to serve. Next slide. That mobile response, these are the core components of a system of care. There's a single point of access. There's mobile response and stabilization, intensive care coordination with wraparound as its practice model to fidelity, and that youth and peer support. Next slide, please. And that intensive in-home services support those foundational or grounding components, that high fidelity wraparound, mobile response and stabilization, youth and peer support, really important parts of this work. And then the intensive in-home supports, which may actually shift and change as the system grows and develops. What doesn't change is the need for mobile response and stabilization, the need for intensive care coordination, the need for youth and peer support. So all of these other things shift and change within the service array, but they need to be available within the service array in order to meet the needs of children, youth, and families. Next slide, please. Single point of access means that we're going to answer the phone 24/7. Parent has an issue, challenge, we're going to pick up the phone, we're going to answer that call, we're going to provide what is necessary. We're going to come if that's it. We're going to come if the parent asks for help. That all calls are answered, that the parent and caregiver calls and the team goes, and that we're going to begin to collect information right from there, right, in a single electronic record that can help us communicate across teams, that can communicate across the system of care. Next slide, please. Mobile response and stabilization, just a quick overview, because you've already heard quite a bit about it today, but it's really important to know that mobile response and stabilization is the first step in systems transformation. The availability of mobile response and stabilization 24/7, the availability of specifically trained teams, and that means, I would argue that you can use bachelor's prepared folks as part of your teams. Certainly youth and certainly peer support partners can be part of those teams, and we see that in second generation mobile response and stabilization. But it is the face-to-face that is really important within the work. Next slide, please. And the goal of mobile response and stabilization, and I just want to leave this, make sure that we hammer this point out, is that we meet the sense of urgency that parents feel with a sense of urgency. Because if the system moves when parents are feeling that sense of urgency, then parents actually can do more of this work than we think that they can. And that more young people can be served in their own homes, schools, and communities than we think can. Next slide, please. Mobile response and stabilization has the home and community-based services. There's all of these components which are really important, but we're not going to spend too much time. We want to get to the next slide, please. Because I do want to talk about care management. Care coordination is something that is necessary in order to transform in in Nevada. It's important to know what care coordination is, what it does, and why it's so incredibly important. Many people just think it's wraparound, and wraparound is important, but how wraparound is provided and the context in which it's provided and who does it is equally as important as the intervention itself. In other words, intensive care coordination is a grounding principle of systems reform. And when care coordination is done well, it transforms communities to become part of the solution. Next slide, please. So next slide, if you could just push that. Yeah, thank you. There's a couple different ways to think about intensive care coordination, but what we know from the evidence is that standalone conflict-free care coordination entities have the best results. And we see that in Louisiana and New Jersey, the two states that have standalone conflict-free intensive care coordination. In other words, what those organizations do is that they only provide care coordination and they connect the dots within the community to ensure young people get what they need. They're also responsible for building part of the service array to ensure young people get intensive in-home services at the time they need it for the duration. There are other models, like Ohio is currently building a model in which there is care coordination in a care management entity, but it's not a standalone, but they have built firewalls. And we do believe that Ohio is going to be successful in their implementation. We also know that Illinois is working on this work. We know Massachusetts has done this work. So is Oklahoma. Oklahoma has some practice models that may actually be really helpful for Nevada in terms of trying to figure out how to get intensive care coordination available to the young people who really need it. Next slide, please. There's care coordination that really look at multiple populations and can serve multiple populations. And there's a couple ways to think about that, right? There's, the New Jersey model is that all populations are served within a care management entity, whereas Delaware, they're served at two different places. There are pros and cons to both models, but we're happy to talk through it. What is important is that young people with both moderate and complex behavioral health needs, their needs are managed within the model that says we're going to coordinate the care to ensure young people get what they need. Next slide, please. And this is just another way of thinking about tiered care coordination, right? And just real quickly, we really want to look at the flexibility in serving more populations. So as an example, New Jersey uses intensive care coordination not only to manage young people with moderate and complex behavioral health needs, but to manage young people who have intellectual and developmental disabilities to ensure that they get what they need when they need it. So really important way of thinking about that. Next slide, please. And this is just our partners, right? Our partners are child welfare, juvenile justice, family courts, education systems. But one of the things I did want to say around this in particular is what you don't want is your child welfare system to have to build its own behavioral health system. We don't want juvenile justice to build its own behavioral health system. You want a behavioral health system that serves young people who touch on child welfare, but those services can be coordinated and can continue whether they stay in the child welfare system or not. The family doesn't have to touch on child welfare in order to access care. Same thing with juvenile justice. So really important way of beginning to think about when and how young people touch on services and supports. Next slide, please. And then it's important to plan from the beginning, right? So we want to make sure that you're moving towards long-term sustainability and that you're using all of the things that are necessary in order to get there, right? If you're going to build a system of care, you want it to work from the beginning. So we want to think, what is it going to look like in 1 year, in 2 years, in 5 years, in 10 years? And I can tell you as somebody who was on the ground in New Jersey in 2000 when the concept paper was published, if you had asked me that we would be here today, I don't know that I would have said yes, but I was certainly hopeful that we would. And we not only met the needs in the vision paper that was published in 2000, we've exceeded that by bringing in new populations and expanding out the service array in order to meet them. Plus, we've met every single goal that we put out. Next slide. So this is New Jersey, and what I put the bridge in there so you can see we want to connect the dots. We want to keep young people in their homes, schools, and communities. That's really important work, and the way to do that really is to connect, right? It is a connection to community, making sure that schools are working with the in-homes work, making sure that people are coordinating across practices, across silos. We want to pull those silos down whenever possible. Next slide, please. And these are our partners. We can move to the next one. And this one's for you, so you know that community engagement is a primary driver of systems reform. In other words, the communities help us figure out how to heal young people and their families. Next slide. I do want to talk real quick about data. There really is important to be able to collect, share, and help communities understand the data, right? So we want to basically collect information that's going to help us know how the system is doing, how are young people improving, right? Can we see that? Can we see that access is taken care of? Can we see that utilization is making sense? So the data collection component of this is important. Next slide. And different uses of data really is in plan. For me, from my perspective, I wanted for planning to help communities understand what I need, for accountability to make sure that we are accountable to the young people and to their parents to ensure access is happening, that they're getting the best service, and by the way, that we're getting the best practices in place in a way that makes sense. Next slide, please. I just want to throw some leadership strategies at you because I think it's important in this moment in time, right, to really think about what do you want it to look like for young people today, 5 years and 20 years down the road. And so a couple of things that are important. One is it is really important to have a vision of what you want it to look like, to believe that young people can be served in their home, schools, and community means that we have to actually be brave and move resources in a way that sometimes might be challenging, but is really important for us to do that. One, and then we need to communicate that vision and make sure everybody knows that that vision is moving. New Jersey was brave enough to put its very bad data into its concept paper so that we could see what improvement was going to look like. That we want to find champions, and those champions are all over your state. You have plenty of people who are interested and motivated for change and ready to do what is necessary in order to meet the needs of these children, youth, and young adults. And that we want to share that progress and report on that progress regularly. We want to be flexible and nimble in the way that we build these systems so that we can adjust as we need to in order for things to work. And one thing we really need to understand is that if you're going to do this work, that people are going to have to change, grow, talk to each other, and be partners within the work. Next slide, please. So we're not going to do questions now, but I promise you we'll do them later. Next slide, please. These are just some resources for you. I think the next one is probably some more resources as well. And one more, I think, is my email address. There's my email address. Happy to answer any questions that we don't get to today or have any comments or feedback. I'm happy to take them as well. Next slide. One more. All right, I'm going to hand to Dr. Freeman.
Thank you so much.
Thank you so much,
Ms. Manley. I just wanted to extend my appreciation for you presenting on this issue area. And we do have a couple questions, so I hope you hang out until the end of this next presentation. But I'm going to go ahead and ask Dr. Freeman to proceed with this portion of the presentation, and then we'll do questions after.
Thank you, Chair. And thank you so much, Liz, for joining us today. We really appreciate your expertise. This is Dr. Megan Freeman. For the record, I currently serve as the state's Children's Behavioral Health Authority. Next slide. Next slide. So I want to start again, like I did this morning, just by going big picture for a minute. I know we're running short on time, and I really appreciate everybody sticking with us through the end of this long day. I'll primarily leave this here for you as reference, but I did want to start the conversation on the children's service array in Nevada by talking about the rights of children with disabilities. We've talked about this a little bit today, and Liz brought up the Olmstead decision. We want to shift our thinking from the ways in which individuals with disabilities are different and what accommodations we can make for a child's limitations or impairments into thinking about what barriers exist within society that prevent that person from developing to their fullest potential. And how can we as a society look at social barriers that we may be able to remove in order for them to have full access to society and fully enjoy their rights. Next slide, and go ahead to the next slide. The important question for children with disabilities, including children living with mental and behavioral health needs, is not whether, but how they can be fully included as members of their families, schools, communities, and society. These are some foundational principles that were decided globally some time ago, and they actually very closely reflect the foundational principles of a system of care, but doing things in the best interest of the child and family, respect for the views of the child, non-discrimination, and making decisions with an eye towards their development. Next. The Department of Health and Human Services is committed to ensuring that every Nevadan has the opportunity to achieve their best possible quality of life. We do have a behavioral health community integration plan, which was published several years ago. We're right now updating it to reflect current needs. And the plan was created with the goal of building a behavioral health system that maximizes community integration and discourages unnecessary use of higher levels of care. But at the same time, we must ensure that services across the spectrum meet all of the needs, including for those who may need inpatient or residential care. And we must attend to prevention efforts and opportunities to divert youth from system involvement. Go ahead to slides. Thank you. So we want to center community integration in our discussion of expanding children's behavioral health services so that we can reduce unnecessary segregation from society and unnecessary institutionalization. In some cases, higher level of care is necessary, but in many cases, when we have adequate capacity for intensive community-based services, like Liz was describing has been the case in other states, such placements can be avoided. Next. So moving towards the discussion of our existing service array, I just want to quickly explain the slides that you are about to see. I'm going to show you our existing service array, and I've divided the services that we do have into several categories. Within each category, there's two slides, one for the lower intensity end of the array, so things like prevention and early intervention, and a second slide for the higher intensity end where the formal intervention services are. And my hope is that looking at the services this way will help you to visualize where we have built out services and where we have some room to grow. Next. So as we look at the development of our service array, if we start over essentially where we want to be, where we have a well-established model, we know how to do something, we have adequate capacity to serve everyone who needs to be served, and there's sustainable funding, we're getting good outcomes. We want to continue doing these things as we are doing them. Looking here at the lower intensity end of the service array, and then on the next slide, Samantha, the higher intensity end, we don't have really any services that I think we can fully put in this category. I am happy to be proven wrong. If anybody here disagrees, please let me know during questions, or please, anybody watching, feel free to contact me back channel. I would love to be wrong about this. But I think in most cases, when we look at our service array, we're missing one or more critical pieces of this: capacity, funding. We maybe yet haven't developed a model here. So go on to the next slide, please. Here we have services that we know how to do it, but we may need to further expand it, like into rural or frontier or other areas. We might need implementation support. We may not have adequate capacity or sustainable funding, or some other kind of support is needed. I also would put respite care here. I didn't put it on the slide, but we've been talking about that today. And I would put that here. We know how to do this. We just need help doing it so that we can get the service to everybody who needs it. Next slide. This is just the higher intensity end of that service array. I put 988 here just because we're still starting, and as we discussed earlier today, when we start this, it will be an iterative process of figuring out what pieces are good, what pieces do we need to tweak, and then the expansion so that it's implemented more like the best practice. Family peer support is an incredibly important part of the service array, and it's currently not a Medicaid billable service, although we are doing some work in that area. Next. This is the part of the service array where significant work remains, or we may be overcoming barriers. I put Project Aware here, as well as trauma-informed schools more generally, primarily because we don't have uptake statewide yet, and this is such a critical part of what we're doing. We really need to see this used more widely. The work that is being done in Project Aware is absolutely amazing, and we want to take it more broadly. Next. On that higher intensity end, where we've got some significant work to do, is a lot of our services, particularly what we think of our key services in a traditional service array, like traditional outpatient services. We're still building out the crisis continuum of care, as we discussed earlier, and then this whole block of intensive community-based services, which Liz mentioned, and which I want to highlight: the wraparound intensive care coordination, intensive in-home services, intensive outpatient, and partial hospitalization. This is where we can serve high-risk youth who are at risk of going into higher levels of care. They may be at risk for involvement with juvenile justice or child welfare. If we can implement these services at scale, we can prevent a lot of youth from having to leave their home and get services somewhere where they may not get the best outcomes. We want them to learn the skills that they need in their natural environment. We're also lacking some specific types of treatment for youth who need to be in a residential treatment environment. Special populations, which I've put here and will come up later, I would consider to be things like that Dr. Brown and her team spoke about earlier, the dual needs youth who have severe emotional disturbance and intellectual disabilities, youth who have aggressive behaviors, youth with substance use disorder needs, youth who are survivors of commercial sexual exploitation, and other populations as well. Next. This is a part of the service array where we haven't started building services yet, or we've tried and there are some substantial limitations. Liz talked earlier about dealing with the day-to-day versus getting ahead of the curve. And I would put these two services here, or it's not exactly a service, but having a state plan and explicit infrastructure for responding to disasters and emergencies. We need to be able to, many youth and families are going to cope just fine, but we need to be able to provide support assessment and early intervention for those youth and families who are not doing okay, to prevent that behavioral health tsunami that we've been talking about and that we're seeing now related to the pandemic. Also, general hospital pediatric consultation liaison services is another opportunity to intervene with families at a time that can be very traumatic. So building and implementing services here would represent an investment in getting ahead of the curve. Next. Again, there are some services here that we're doing really, really well, such as the school-based behavioral health services, multi-tiered systems of support. But when we look at those tier 3 services where youth need individualized interventions, where we want to provide them with traditional therapy services on site at school, that's where, although some parts of the system are built out well, some parts we still need to put more attention to. We do need to put more attention to the substance use service array, although we had a great talk earlier from SAPTA, and then care coordination for youth returning from higher levels of care, I think is a key part of the system, because as Dr. Andrew Freeman mentioned earlier, it's an opportunity to catch youth at a vulnerable time and prevent further system involvement. Next slide. I do want to talk about bed availability briefly, because this is a topic that comes up frequently with respect to Nevada. This is also an issue elsewhere right now outside of our state for lots of reasons. But using recommendations provided in a recent paper from, which is coming out of a panel of global experts with respect to acute psychiatric hospital beds, so not residential treatment beds, that's a separate issue. Acute psychiatric hospital beds for youth who are in imminent danger, they need to be in the hospital for several days or a week. It looks like we are experiencing a severe shortage. We should have somewhere between 30 and 60 beds per 100,000 youth, and we have between 13 and 15, depending on how you look at it. And this is one of the reasons that we see bottlenecks in the emergency department. We also have a discrepancy right now between licensed beds and staffed beds that's related to the workforce shortages. So although a facility may be licensed for example, 20 beds, they might only be operating 16 beds due to staffing shortages, which further limits the ability of the system to meet the needs. Next. So related to this is the idea of the behavioral health safety net. And a generally accepted definition is a set of services for low income, uninsured and underinsured children, youth, families, and adults. The services are relatively easy to access, and they're adequately funded so that nobody who needs the care would ever go without care. And typically, this is your public behavioral health system, probably provided by a state or a county, or through some sort of contracting process. Next. In Nevada, we do have some statute related to this. So there's some clear legislative intent. This is regarding the purposes of the Division of Child and Family Services. And the purposes of the division are to provide a comprehensive system, not only for juvenile justice and child welfare, but also for the mental health of children. This includes ensuring that they're placed in the least restrictive environment, and coordinating and providing services for youth. And this doesn't necessarily mean literally the state provides all the services, because as we've been talking about today, that's clearly not a good strategy. We're not going to be able to meet the need, but it is the responsibility of the state to ensure that an adequate service array exists. Next. So just a little bit more here on the ways that this touches on behavioral health. So the division shall establish and coordinate a system for diagnosis and assessment, referral to appropriate services, and care coordination. And so without the proper infrastructure, oversight, data monitoring, it would be really difficult for the state to execute this area of the legislative intent. This is a big ask. It's really, really important. And right now we are lacking some parts of our service array. And so it's something that we need to pick up, but we also need to make sure that we have all of the tools that we need in order to be able to do this. You can go ahead 3 slides, Samantha. So that's the generally accepted definition, the legislative intent, what we know that we should be doing, we would like to be doing. And the post-COVID reality is that, as we've been talking about all day, we've got folks leaving the workforce. Those who are left behind to carry the load are incredibly burned out because of the shortage of healthcare professionals overall. And I found an interesting statistic while I was researching this. This goes across all industries, not just healthcare, but the majority of those leaving jobs in 2021 cited mental health as the driver. And for quote unquote millennials, that was 2 out of 3 folks. And for Gen Z, the younger generation, who's the newer generation in the workforce, that was 4 out of 5. So it's 80% of folks saying that when they left their job, the reason was because of their mental health. Next slide. So not only is our workforce struggling, but the mental health workforce shortages are affecting the care of youth and also adults. Virginia stopped admissions to 5 of its 8 state hospitals due to their staffing shortages, and folks are leaving community mental health clinics because of low salaries and burnout and other reasons. So it is difficult to serve in that role as the safety net, not just performing the services, but also coordinating the services, ensuring they exist when we're missing some of these key parts and working in this incredibly difficult time to provide healthcare services. Next slide. So moving on to where we go from here. You've heard today from a wide range of folks, and many thanks to all of the awesome people who testified today. We have an amazing team at the state and also our local partners. There's a tremendous amount of really good work happening here, like Dan said, to support children, youth, and families. We're supported by the governor's office and his staff. We're supported all up and down the line. We also do still have a lot of work left to do. When we look at the service array from a 30,000-foot view, we can see that we're lacking evidence-based and evidence-informed services at the right capacity, supported by sustainable funding. The recommendations, or at least one of the recommendations to start addressing this, is to improve data collection and surveillance efforts so that we can fully understand the need. This is the first step in creating the infrastructure I've been talking about that can address the quality and completeness of the service array, and will also inform requests for funding strategies. The next area of our service array that needs to be built out is intensive community-based services, which I showed you earlier on the service array slide: partial hospitalization, intensive outpatient, intensive in-home. Wraparound and intensive care coordination services should be the bone of an individualized strategy for every youth accessing these types of services. And using this strategy will provide the best possible support and outcomes to youth who are at risk of out-of-home placement. Next. We do need to significantly increase capacity to provide those wraparound or intensive care coordination services. Again, the state can't provide all those services right now. That's the model, but we have put in some requests to expand and engage community partners. This will allow us to better support youth who are at risk, which includes not only risk for higher level of care, but also risk for involvement in the juvenile justice system or the child welfare system. And in the event a youth does need higher level of care, this is another area of our system where we have significant and meaningful gaps, which again has come up earlier today. Youth with specialized needs do tend to go out of state, such as youth with comorbid intellectual and developmental disabilities. And community stakeholders have lost confidence that our in-state residential treatment system can meet the needs, even for youth who do not have specialized treatment considerations. So we need to take a look at our strategies here with regard to residential treatment and make any adjustments that might be needed to ensure that we're aligned with best practices. Next. So the second bullet point is on workforce challenges, which I'm sounding like a broken record at this point. We've discussed potential strategies like creating a pipeline from local institutions of higher education and explicitly incentivizing behavioral health care work. We could use strategies such as student loan repayment or even cash bonuses. And while public employees, including school district employees, are feeling the largest salary gap with the private sector right now, it would be beneficial to be able to provide incentives and bonuses across both public and private settings. But what I'd really like to highlight here is the opportunity to build out school-based behavioral health services. You heard earlier from Director Christine McGill, as well as the Clark and Washoe school districts, the extensive and very thoughtful programming that is already happening in our schools. But we know that especially for those in need of those highest level tier 3 services, which would be individualized interventions, what we have now is not enough. Director McGill mentioned the use of Medicaid dollars. So we do have a small team of folks working across the Department of Health and Human Services, and within there across multiple divisions, as well as the Department of Education to support the implementation of Medicaid billing in schools. The revenue will be reinvested in schools to further build out behavioral health services. But not every youth who needs behavioral health services is Medicaid eligible. So we want to dedicate more staff resources and more funding to take school-based behavioral health services to scale statewide. And this will increase access for all youth and allow for more equitable service delivery by removing barriers to care. Can you go to the next one, Samantha? I want to do these out of order. So this is not the questions, the one, there you go. Yes. This is just the final point that I wanted to make. Liz earlier mentioned the importance of oversight in ensuring that best practices are delivered and youth are receiving quality care. And she mentioned that the way to accomplish this is by having a dedicated team of folks attending to this infrastructure. And you also heard earlier about an infrastructure like this used by SAPTA in Nevada to oversee the substance use prevention and treatment system here. We want to do something similar to what SAPTA has done for substance use provider certification and treatment for children's behavioral health. We want to know how many providers there are, what services they're providing, and we want to certify them through a vetting and enrollment process so that through these processes we can better ensure that there's a full and adequate service array. This will also give us oversight over services and outcomes, which helps to better ensure clinical quality. And as the other Dr. Freeman mentioned in his talk on pushing mobile crisis services out to the community, when we start growing the community-based service array, it's very important to ensure that the standards of care and best practices are maintained. So we need these formal mechanisms for oversight, quality assurance, and quality improvement. We don't want to make the process so burdensome that providers don't want to participate or they can't meet the requirements. But we do need to strategically monitor certain metrics so that we can provide training and technical assistance and corrective action as needed, and so that we know what's happening in the system. Samantha, can you go back one? But we don't want to set expectations for providers without providing the scaffolding to ensure that they can meet the expectations. So the previous slide was the policy and oversight side of the house, and this is the clinical excellence side of the house for the Nevada Children's Behavioral Health Authority that we would like to build. So the clinical excellence side of the house is designed to support both providers and the service array overall. And these different offices and centers on this slide here would work collaboratively with those on the policy and oversight side to ensure that the authority is providing adequate support and attention to clinical quality. The state would make technical assistance and training available, which includes engagement with vendors and providers of evidence-based models of care. There would be several areas of the authority specifically dedicated to specialty areas of youth treatment like substance use disorder, school-based behavioral health, and then the special populations that I talked about a few slides ago. Underlying all of the work of the authority will be support for whole child and whole family health, awareness of the significant impact of the pandemic on children and families, and awareness and mitigation of social determinants of health. And in some senses, showing these separately is an artificial separation, and even putting these offices into separate boxes is an artificial separation because there's so much interdependence among training, technical assistance, oversight policy, working with Medicaid, working with the Department of Education. We're already doing the interdisciplinary thing, and this would be sort of further integration in an interdisciplinary manner to fully support the needs of youth and families. So we've been talking today, the sort of overarching theme that I hope you're hearing is that we need behavioral health system transformation. And it is hard to achieve radical change incrementally. This is the time, this is the opportunity to leverage the current environment that is ready and willing to talk about the needs of children and families and ready to talk about making changes so that we can achieve that radical change with some big ideas. That is the end of my presentation, and Liz and I are happy to take any questions.
Thank you again for presenting on this really important issue. I really appreciate the kind of outline of what you guys are thinking about, and I look forward to continuing to work toward what it is you need to stand this up. I think we need to talk about the funding piece. That's a very separate and robust conversation that we should be having, as well as what infrastructure do you need in addition to that funding piece to stand up this type of model. I love this. Everything that you are discussing related to the transition into this care model is spot on for me and my experience as a millennial with children, and also having dealt with my own mental and behavioral health issues while being a support for other people who are as well. So I'm very excited for us moving in this direction, and I'm hoping that we can tie some things together this next legislative session. So I look forward to your recommendations on bill draft requests. I have a question for you, but I'm going to go ahead and start with my committee. Are there questions from the committee based on this? These two presentations.
Madam Chairwoman?
Yes, please go ahead.
Thank you. There's a lot of echo here because our room is kind of empty, so but I'm still here. In any case, just a quick question. First, thank you for the presentation. I do think that there has to be a change, and we certainly have to augment what we're doing. And I recognize that we are on a policy committee, and that, as the chair pointed out, I think most members of the HHS committee are also on the money committee, the interim committee. My question for staff, and perhaps I could get it to us, is how much has our ARC funds, how many dollars of our ARC funds have actually been committed to our mental health programs, and I'd like to see where that, if any of that money's been spent to solving some of these issues that we have been presented over this day, because I think I'd just like to see kind of that total, and maybe staff can get it from our finance folks. So thank you, Madam Chair, for that.
That's a great question, Dr. Titus, and I think that we'll see some additional information on that during the next IFC meeting. So, so I think that will be taken care of in the Money Committee and clarified in the Money Committee. I know that's a little ways off, but we should expect that paperwork to come in anytime between now and probably the first couple weeks of April for us to review, if not a little bit later than that. Are there other questions from the committee? I think I've got 3 of you left. Thank you for hanging in there. Okay, I'm going to go ahead and ask my question. So as we work to stand up this type of system, how do we communicate with parents and work to destigmatize the ask for help? I don't believe the service is meant to be a last resort, but instead is designed to be a community support, much like the saying that it takes a village. If that's incorrect, please correct me. But I think that there's a gap, right, on how we communicate that purpose within the community. And how do we get parents to call and let these supports help them and their families? And maybe that's a question for all of the folks who have participated in the meeting today, but if you have any response, I would appreciate it.
Yeah, absolutely. So I think what's important is, first of all, making sure that you have the services up and running, because you don't want to let parents down, right? We don't want to do that. But what also is important is that as you're rolling things out, you're going to get out to parent groups, right? And you're going to ask parents to try the service. You're going to ask them to trust you, right, in the work. And as you move out, parents will do that. They'll come once they have a good experience, once they've experienced. As an example, you're beginning to see that in the world of mobile crisis response, right? Parents are experiencing the service, they're getting what they need at the time they need it. The more you can do that, the more you can demonstrate to parents to use the service. But one other lesson from 20 years on the ground is that you have to continually communicate. Like, we can't let it go. We always have to be really attentive to communicating with parents, with schools, with pediatricians, with law enforcement in particular. We need focused attention in those areas, because when parents begin to experience challenges, they talk to teachers, guidance counselors, they talk to pediatricians, and they come across law enforcement from time to time. And so we want everyone working on the same page. But that's really how you do it: slow, easy, making sure parents, use the service, making sure you advertise. Sometimes we put things in young people's backpacks as they go home. We spend a lot of time talking to vice principals, in schools to make sure that they know, guidance counselors. All that communication is really important.
I agree. And having lived in Nevada all my life, I know that we have a little bit of a tie into fierce independence. And so it's really hard to break through that in our communities. But finding those community partners, I think, is really key, and then keeping them engaged. But I look forward to seeing how we do that, and if we need to maybe make a robust coordination office to ensure that that's happening. And across the board and continuously, as you said. Thank you so much for that response. Are there any other questions from the committee on this presentation? Seeing none, I'm going to go ahead and close out this item. Thank you so much for being here. Really appreciate you. I know you're a couple of hours ahead of us, so thank you so much for your evening today. And thank you, Dr. Freeman, for all of the information provided today. Really appreciate you being here. And with that, we'll move into our last agenda item today, public comment. We'll start with public comment from those in the physical locations. I have one person here in Carson City, and she's not coming up to the dais, so I'm assuming I do not have public comment here in Carson City. Is there public comment in Las Vegas? And also, as a reminder, anyone who's coming up for public comment, please clearly state and spell your name and limit your comments to 3 minutes. Staff will be timing the speakers to ensure that everybody has a fair opportunity. I am not seeing Las Vegas, but it sounds like someone may be there. So please go ahead when you're ready.
No public comment here.
Oh, okay. Thank you
No
so much.
one here in Las Vegas.
All right. With no one in Carson City and no one in Las Vegas, I will turn to broadcast and production services. Are there folks on the line? Actually, let's give it a minute to see if folks call in. I know there's a delay and sometimes it takes a minute to call in. So we will give it a minute for broadcast services to see if anyone calls in on our public comment line.
Thank you, Chair. Broadcast standing by.
All right, broadcast services. Is there anybody on the public comment line?
Thank you so much, Chair Peters. The line is open and working. However, there are no callers at this time.
All right. Well, thank you all for hanging in there for a long day. This is an important issue for the state of Nevada, and especially for those of us who are very passionate about this space. So I appreciate everyone hanging in there, and I appreciate all the folks who are working in this area. Thank you so much for your time and effort today, for the information you've provided. With that, our next meeting will be held on April 21st, 2022 at 9 a.m., hopefully in person, and the meeting is adjourned.